Good afternoon, everyone. I call Committee of Supply Section A to order. We're meeting today to continue consideration of the estimates of the Ministry of Health, and I will now recognize the Minister to move the vote.
Very much, Honourable Chair. I move vote number 32, resolved that a sum not exceeding $28,526,258,000 be granted to His Majesty to defray the expenses of the Ministry of Health, Ministry Operations to 31st March 2024.
Thank you, Minister. I now recognize the member from Prince George Valemount.
Thank you very much. And the minister's getting quicker at reading off that very large budget number. I'm going to start this afternoon. We're going to wind our way through some of these questions. We're going to try to pick up the pace a bit this afternoon, but I'm going to start with having my colleague from Peace River North ask a question.
Recognize the member from Peace River North.
Thank you, Madam Chair, and good afternoon, everyone. Good afternoon, Minister. So my question, it is one question, and it has been asked before, and I have had a conversation with the Minister in the past about it, and to no commitment yet, and that is about a Northern Health audit. I know that there has been discussions. There's been a growing number of local governments that have also been asking that the government look at doing an independent audit. There's also organizations that are now doing this. I even understand that it's growing even beyond just Northern Health, that there's, looking at audits for the other health authorities and generally the Ministry of Health. And I think it's really important, and I had this conversation with a number of my, local elected officials up in my area, and it's good practice. It's not a matter of playing a gotcha. It's not a matter of any of that. It's a matter of let's find best ways that we can move forward and deliver health services for our residents. And I hear this all the time from residents in my area, as well as people that I touch base with throughout the province, is we need to do an independent third-party audit, and in this case, of Northern Health. So my question to the Minister, is there any plans in the near future to undertake this?
Minister.
Thank you very much, Honourable Speaker and Honourable Chair, and thank you to the member for the question. I know he shares with me the importance that Northern residents, Northern people who live in the Northern Health region feel about healthcare and its central importance. We've had some occasion in these estimates, I know the member will have been following those occasions, to talk about the very effective measures that Northern Health has led in challenging times to address health human resources issues that we've had in Northern Health. I think, and I say this, and I don't think the member's disagreeing by asking his question, I want to make that very clear. We've had an outstanding CEO who's served Northern Health since 2007 under multiple governments, who is extraordinarily accountable to communities in detail in all of her work. We have a board of directors of Northern Health led by Colleen Nice, who's from Terrace, that represents people from across Northern Health, including his community, including the Dawson Creek, and communities across the north, which I think does a very effective job of connecting to communities and bringing accountability to boards, of engaging with communities as well. Colleen Nice, as members of the House will know, served on the Northern Health Board before I became Minister of Health, was named chair when I was elected Minister of Health, just after I became Minister of Health, and I think she's both an outstanding representative of the North and has done an excellent job as chair. Northern Health continues, in some of the most extraordinary of circumstances, to deliver services with commitment to the people of the North. On the capital side, as the member will know, we've seen the most significant capital effort that the Northern Health Authority has seen, with new projects in Terrace, new project in Fort St. James, hospital project just finished and just open project in Quesnel, a major project in Prince George, major project in Dawson Creek, in addition to all the work we're doing across the North. So I think that it's the responsibility of health authorities to engage with communities, to engage with local MLAs, to engage with local mayors, to engage with local communities, and engage with citizens, because it's our public health system. I don't feel, and the member knows this from our discussions in the past, that the kind of audit that he's suggesting, and let's be clear, Northern Health is regularly audited in the normal process of events, but I think he's calling more for a review, I think, than an audit, and I understand that. And we do a lot of work on the efforts in communities to make changes. He'll know, for example, with respect to surgery, we've made some changes recently that when we made them, we spent a lot of time consulting and engaging with communities, including with him, and his involvement and input was both appreciated and I think played a role in the decisions we've made. So we're going to continue to ask the Northern Health Authority to engage with communities. We don't believe that an independent audit is in order at this time, but I accept and understand the concern that Nairs and the member are bringing, and I think the task of Northern Health is to engage with communities, and that's what they do.
Member.
Thanks, Chair. And you know, it's not that I disagree with everything that the minister said, and I do believe, you know, Kathy did a great job. You know, she's now retiring, and there's individuals, of course, within every health authority, certainly Northern Health being one of them, that do an exceptional job. But I can tell the minister this, that it is the #1 complaint call that I get in my office. By far exceeds all other issues that my office receives. And I can probably talk to many, all the other MLAs, that probably might be one of their top calls that they also receive in their offices. And, you know, the issues, and I won't hold back, they range anywhere from, you know, unbelievable wait times in emergencies, of course, our challenges with recruiting and retaining doctors and nurses and other healthcare professionals. And a lot of those we hear are because of what is happening within the system. It's not that they don't want to live in said community. It's what is happening within the system, within the health authority. You know, we hear about the, you know, and this is one thing that is, that I just had a meeting here about 2 weeks back, and it's been ongoing, is toxic workplaces. Hours and hours, you know, people being driven into the ground, and you know, massive burnout. So we do see these continued issues that are coming up over and over and over again. And I know the minister's had, I'm sure, emails and phone calls to his office about all of these. And I think that is the biggest thing. And to clarify, I am calling for a corporate audit of Northern Health. That is what is being called for by myself. There are other MLAs, local government officials. I believe even there's going to be a resolution on the floor at the NCLGA, the North Central Local Government Association, talking about this very issue, because there are concerns and things do not seem to be getting better. So I do implore the ministry to look at undertaking or moving toward that corporate audit to find out where we need to do better. And often having that outside agency looking in, I know when I was a city councillor at the city of Fort St. John, it was the best thing we ever did. Bringing in after a number of years and hearing, you know, these issues, having that third party come in and say, here's where your issues are. Sometimes you don't see them when you're within. So that is what I'm asking. And I do, again, want to see if there's any plans, or if maybe we have this conversation in the very near future and talk about what that might look like.
Minister.
Thank you very much. And I won't go through. We've had, with the member for Prince George Valemount, we've had an extensive discussion of recruitment efforts in the north, and we'll just say that part of it is asked and answered. Those efforts have been effective. They've been driven by Northern Health, and we need to do more of them. The new doctors agreement, the new nurses agreement are focused on issues in Northern Health. The new relational security model in acute care focused on communities and came from recommendations from people in Northern Health. The fact is that Northern Health had the lowest level of diagnostic care of any jurisdiction in perhaps the country, certainly way less than any other jurisdiction in BC. 22 MRIs per 1,000 when I became Minister of Health. We've now more than doubled that over the last few years, and a major beneficiary have been constituents of the honourable member. So we don't need to have a full debate about all of the issues in Northern Health. I just say that I appreciate as well, from the suggestion of the honourable member, his regular contributions and his personal advice to me in crucial moments. I don't forget that. So I believe that Northern Health is doing a good job, is fulfilling its mandate. that it faces challenges that other health authorities don't face. We've got to continue to find innovative solutions to retain people, to innovate in the healthcare system, to, of course, recruit people. And you see this in both these agreements and the actions in the Health Human Resources Plan, which we've discussed. So again, I won't repeat those discussions, but I hear what the honourable member is saying and the issues that he's bringing to this House. But I respectfully disagree about the need for such an independent report. What we need, what people in the North tell me we need, what opposition members usually tell me they need, is action and not reports. And that's what we continue to intend to bring.
Recognizing the member from Prince George Valemount.
Thank you very much, and thanks to the Minister for his responses. And I really want to thank my colleague from Peace River North. I know how hard he works on behalf of his constituents, and today he is reflecting the concerns that people where he lives and in the region are expressing. And I think it's important to acknowledge that, as the Minister has, and we all need to encourage the system to respond to those concerns. So thank you to the Minister. I'm going to ask a couple of questions and then I'm going to go back to, I'll give the Minister a heads up here. I'm hoping that he will have specific UPCC information for me as he did last year, but I want to quickly go through a couple of other issues and then we'll go back to UPCCs. One of the things we've heard about from physicians and concerns have been expressed is about not receiving timely payments, and it's not everyone, but some physicians in terms of payment from MSP. Invoices get submitted and then they get rejected multiple times. It's been an ongoing problem. And for some physicians, it's been at least 2 years. And the concern we hear is that the resubmission process takes a long time. And the government, through MSP, has said it's a glitch. It's an issue between MSP and the electronic medical record system that some physicians use. So I, first of all, want to confirm the Minister is aware of that situation, and I would like to hear commitment to solving that problem if it hasn't been solved already. Physicians have enough challenges. The last thing they need to be worried about is whether or not they're going to be reimbursed by MSP.
Minister.
So I would say that physicians have brought these issues to my attention from time to time. We actively manage this issue. It's an important one. The volume is, as the member will understand, massive in terms of the number of visits and the number of billings. Occasionally in that system, the fee-for-service system that we've had, there are mistakes in paperwork because there's too much paperwork, frankly, and mistakes on our side, and we actively manage those issues. One of the good things about the new payment arrangement is the work that's been done. It didn't get as much attention as all the family doctors things, but the work that has been done through this discussion of the physician master agreement between the doctors in BC and ourselves, in both reducing the amount of paperwork which we want, of giving doctors, physicians, and others support and administrative support and time to do some of the very significant work they're done. And I think the model itself is geared towards providing more care and doing less paperwork. And that is a good thing. And it's one of the reasons and one of the active goals both of the government and of the doctors of BC in those discussions.
Member.
Thank you to the Minister, and I certainly understand the massive volume of work that's undertaken. But I'm sure, and I know the Minister understands this, it's a very difficult circumstance when that happens to a physician, especially when you think about family practice and the margins and all of the challenges with all of those things. So I wanted to raise it to make sure that it remains on the Minister's radar screen. I want to move quickly to the gender-based fee review. It's my understanding that under the Physician Master Agreement, there was a commitment to conduct a collaborative review of the payment schedule to identify whether there are inequities in fees for services provided to patients who are women or gender diverse, as well as inequities in fees for services provided predominantly by physicians who are women. So obviously, critically important issue, and I'm wondering if the minister can confirm, is the review underway, and when does he anticipate that work would be completed? Will he be making the information public so that we know that if there are gaps or inequities, that will be rectified?
Minister.
Thank you, Honourable Chair. Yes, it was in the PMA. Yes, we're beginning to work on it. Yes, it will be in public.
Member.
All right, I'm impressed. That was the quickest answer by the minister so far in 3 days, and I am celebrating that. And the Minister of Post-Secondary agrees with me, so I feel like I'm on solid ground here. Let's talk a little bit about the UBC School of Medicine expansion. Always good news when we see more spaces and the expansion of training spots. So could the Minister tell me what startup and sustained funding was provided for the expansion of UBC's School of Medicine as it was announced last fall? The backgrounders in September said that this optimizes the existing capacity at the UBC Faculty of Medicine. We also noted that there was a comment that they're still waiting for startup and sustained funding. So could the minister assure me and outline for me that startup funding and sustained funding was provided for that expansion?
Minister.
Thank you very much, Honourable Chair. Just to give the members the number, so there's the undergraduate increase in spaces, and there's the postgraduate medical education expansion. And I got to work on this because the Minister of Post-Secondary Education's here, so I got to get these things right. She routinely finds it when I'm not. Undergraduate medical education expansion, 2022-23 is $4.85 million. That's the fiscal year that just ended. This is the undergraduate, 8.21 in 23-24, 9.66 in 24-25, 17.49 in 25-26. For the postgraduate, it was 1.82 million in the fiscal year that just ended, March 31st, 2023. But then it picks up because most of it wasn't in that year. Is 12.38 million this year, 21.46 million next year, and 27.74 million in 25-26. It's funded and it's on track. And so, and we obviously appreciate UBC's commitment to this effort. I think it's very important. It's funded, as well as obviously all the work we're doing with SFU.
Member.
Thank you very much to the Minister for those numbers. I'll certainly take a look at them after we finish estimates. While we're on the topic of medical schools, I'm wondering if the Minister can tell me if he anticipates receiving the business case for the SFU Medical School within this year, and what the expectation is in terms of when that might be received.
Minister.
Thank you. So SFU is working to a date of May 31st this year. I would say that there may be more questions on this subject. And while the minister's here, I think her estimates are still open and upcoming. So, I mean, I'm sure that she'll be responding to some of those questions. But yes, that's when the business case is expected. And going forward, of course, the dean is in place, and I think it's really exciting for SFU.
Member.
Well, thank you very much. And I know that my colleague, the Shadow Minister for Post-Secondary, has a number of questions for the Minister. So I just wanted to make sure we know how long it takes to train healthcare professionals. And so what's critical is that we expedite and get moving. It's one thing to make a promise. It's another thing to actually deliver those spaces and get have people into the system as quickly as is possible. So I want to go back now to UPCCs. I thought we had a good conversation about community health centers and about primary care networks. I should say that I thought the discussion on rostering was really helpful. I actually had somebody ask me last night, how do I get on that? It was like, well, just check out Hansard. I'm sure we can walk our way through that. So that was very helpful. So let's talk about UPCCs. Can the Minister tell me, in the last fiscal year, how many patients were attached to a primary care provider at a UPCC?
Minister.
So I'll do a little compare and contrast for the member just to get started. And if we take, I'm going to compare period 10. There are 13 periods in a year, 2 weeks, 4 weeks per, on 52 weeks. So we're comparing period 10 of 21-22 to period 11 of 22-23. In period 10, 21-22, there were 290 FTEs. In period 11 of this year, which is of last year, I should say, which is about 2 months ago, there were 416. There were 26 UPCCs. There are now 30 UPCCs. At that point, there was, at period 10 of 21-22, there was 1.08 million visits. Period 11, which is in February this year, there's 1.7 million visits, so you minus the two to get a sense of the annualized visits. So because obviously UPCCs disproportionately provide episodic care, and they have, particularly in this period. And I've made the case to the member before how valuable they've been in communities at a time when many doctors have been were giving care virtually. So that's been their primary function, and we can go through the visit area. On the attachment side, which has not been their primary function. There are some UPCCs that haven't attached but have been extremely successful in terms of visits, such as Kelowna, which is our most successful. It's not been a place of attachment, it's been a place of urgent and primary care, and that's been the strategy. So the total attachment is 25,881. Total visits, though, as a period of 11 was 1.7 million visits.
Member.
Thank you to the Minister for that. I'm wondering if he could tell me, and again, if he wants to provide me with a chart or however he would like to do that, that is fine. What is the average annual budget of a UPCC in each health authority? And I'm very specifically interested in the one here on the West Shore, if the minister could provide that. But I'm very interested in knowing what the average annual budget of a UPCC is. And the minister knows that there's been a lot of discussion about looking, and again, I'm always careful to remind the minister this isn't about the people who work in them and all of those things. But we want to make sure that when we're making significant investments of taxpayer dollars, we also want to make sure the system is working, that results actually matter. So if he can provide me with the average annual budget of a UPC in each health authority, and specifically the numbers for West Shore.
Minister.
So what I'll do for the moment, just to keep the discussion going, but this is a response by health authority about all of them, because that's how it's been framed. And what I'll talk about is two things. One, obviously not all UPCCs are the same. Some are much bigger and are producing much more visits, such as Kelowna, for example, which has been remarkable in the number of patient visits it's received, and it's also bigger than some of the others. Kelowna is 25 FTEs, for example. West Kelowna is less. Right? The member will know this. Kelowna is a bigger UPCC than West Kelowna, so it would have a bigger budget, budget for 25 FTEs and 15 FTEs, and they're different. But let me give it to the member by health authority. And some health authorities and communities are better suited, clearly better suited in urban areas, although one of the most successful UPCCs we have is in Cranbrook and in the riding of the member for Kootenay East, which has been off to a remarkable start, in fact has beaten all of its projections in a dramatic way. So across health authorities, let me give you the annual operating budget. FHA is $24.8 million. IHA is $15.7 million. Northern Health is $2.1 million. We've had different models, but there's Prince George and Quesnel in that case. Vancouver Coastal Health, $26 million, $26.4 million, but give the exact. Vancouver Island Health, $33 million. And that's the total UPCC budget across the health authorities. So obviously different health authorities have different numbers of UPCCs and different demands in the process. Others have had priorities on other things. It's not my view that every community is suited for a UPCC, but obviously they're most suited in larger and medium-sized communities, and some of our most successful have been in both, from Prince George, where we have a very different model of a UPCC than we do, say, at the Surrey Centre one, the Surrey Newton one, or others. But so there's different models everywhere, but those are the overall budgets.
Member.
Thank you, Madam Chair. I'm wondering, when the ministry counts patient visits to a UPCC, does the government combine visits to physicians, nurse practitioners, and registered nurses together, or is it separated out? Is it differentiated when the count is done?
Minister.
So what that reflects are the family physicians and nurse practitioners, those visit numbers. But obviously the work of urgent private care centers involves many others, lots of allied health professionals who provide supportive work and are part of the team. But when we're counting visits, we're not triple counting in a way. They're the NP visits, the family physician visits, and we're working as we provide more information on it to track that other work that's done. I'll just give just an example for sake of argument. We've been talking about the Cranbrook Urgent Primary Care Centre, and that's why it shows work. In that case, there's a really need for allied health professionals in the community. 7.3 of the 14.9 FTEs are actually allied health, and this is what the community of doctors wanted to support in Cranbrook. So it's actually, in that case, 0.9 physicians, although they get other supports. In some UPCCs, the physicians are provided through fee-for-service, or happen, right? And then it's 1.7 nurse practitioners, 5.0 nursing, 7.3 allied health professionals at Cranbrook. That's an example of one of them. And so, yes, we have to measure that, but in that case, we've really had a positive response, which shows that it can't be the same UPCC in every community, but that's the balance there. But what we're trying to show with the visits is principally that we count it through family physicians and nurse practitioners.
Member.
Thank you to the Minister. That's helpful. Can the Minister tell me if all UPCs are now fully staffed, and if it's possible for him to tell me which ones are not?
Minister.
So what I can do is sort of give a general view of that, and we'll see if we're getting at it. As I said, we've had a very good year for recruitment of UPCC, understanding that there are 4 more net, right? So that's part of it. We went basically in period 10 of the last fiscal year, which would have been end of January, I think, of 2022 to February 2023. We went from 290 to 415. So we've had a good recruitment period. Every organization, when I reported last year, I think we had a debate last year, Kelowna was fully staffed. People move in and out in healthcare all the time. So in this period that we're talking about, Kelowna was at 22, I think. Fully staffed was 25. That's the natural process. There's a churn to that process. Where the member would be correct, or where the concern most significantly is, if you look across UPCCs, is on Vancouver Island. That's been where the biggest challenge has been. The one that the member was referring to on West Shore has been in some ways the most successful in terms of staffing, and is connected to other primary care services very well as well, and the new CHC in the region. Some like Nanaimo are harder to judge because the physician staffing in Nanaimo is fee-for-service. So it's the rest of the staffing that you're judging. So it's only 10, even though it's a UPCC that's actually quite successful in terms of treating patients. And so across the board in terms of the total recruitment, we're at 100% or close to 100% in probably 12 of them. We're between 80 and 90 in the lion's share, and then there's some under 80% of what we wanted. And so what we've done in a lot of UPCCs is we're building out, and the last stage will be to support attachment more. But the key aspect, especially given the most recent agreement and the work we're doing with the doctors of BC, is to continue to use UPCCs to support episodic care, and that's a key contribution that they make in communities.
Member.
Thank you. When to the Minister, when a UPCC is considered fully staffed, does that include a mix of permanent staff, temporary staff? Is it a mix? If the Minister has said that there are likely 12 that are at 100%, would that include a mix of staffing arrangements, permanent and temporary?
Minister.
One of the main differences on physicians. So at some of the UPCCs, they're not staff or staff positions. They are paid for through fee-for-service. So it's working with the local division of family practice and staffing through fee-for-service. And we see that in some cases. So that's a difference. They're not staff against not staff. That's the model that has been selected. We have different models, as we've discussed this before, in Vancouver City Centre. That was through a provider, a noted provider in Vancouver, who was providing that on behalf of the health authority. In Nanaimo, that's the medical arts. In other places, in Prince George, it's a very strong and interesting partnership with the Division of Family Practice that the member will be aware of. So there's two things that I would say. One, it's team-based care. So everywhere we see a combination of, so let me just give you, I said it was 415.7, to give the member a sense. That's the actuals. This is the actuals hired in UPCCs, 92.7 physicians, 48 nurse practitioners, 187 nursing, and 74.8 allied health. So so when we're looking at who's being hired, that's the mix. And I think one of the challenges, and it's an important challenge, but we can get to continue to build out both physician care and nurse practitioner, because is to continue to ensure that those services are in place, because for a lot of the episodic care, that's really important. But the team-based care is one of the things that makes UPCCs and primary care networks, I think, unique and a positive resource in the community. And so that's the discussion. So principally, if you look across that, those are our full-time staff. But an FTE amongst physicians, say there are 5 physicians sharing the position, might be 0.2, 0.2, 0.2, 0.2, right? Something like that. The other staff tend to be more, just one person, one FTE.
Member.
Thank you. I would like to ask a specific question about the Chilliwack Primary Care Centre. How many physicians and nurse practitioners have been approved for funding at the Chilliwack Primary Care Centre, and how many are currently employed on a full-time basis?
Minister.
What I have is information on the Chilliwack PCN, but I've asked the staff, unless the member wants to wait for the answer now, just to keep going, and then we'll get that answer to her as soon as possible, and then we can have the exchange perhaps on Chilliwack, if that works for her.
Member.
I appreciate that. I probably won't pursue that, further questions around that. I just would like to know those numbers related to an issue that I'm working on. So when the minister initiated the primary care refresh last fall, was there a formal review or evaluation with regard to the governance framework, the implementation, and the operations of UPCCs? I think all of us know that nothing's perfect the first time you roll it out the door. So I think ongoing evaluation, looking at monitoring and looking at where there may be gaps. So is there a planned formal review or evaluation?
So there's something called the Family Practice Services Committee. And so this isn't specific to UPCCs, it is to PCNs, and obviously UPCCs play a role in PCNs everywhere. Dr. Sari Cooper and the person just behind me, Ted Patterson, on the screen to my left, and I think to my right. Mr. Patterson is the co-chair of that with Dr. Cooper, and there's been a reach out everywhere to the partners, which include Indigenous communities, local communities, other health professionals, and of course doctors, that reach out to see where the PCN process is working, where it's not. So that consultation has happened, and obviously UPCCs are part of that. So that's not exclusive to UPCCs, but it is to primary care networks of which UPCCs are a part.
Member.
Well, thank you. And I think that work is really critical because, we look at, and I've seen it firsthand, people line up first thing in the morning, in many cases, to get into a UPCC, and it's full by 8:15 in the morning. And so I have a concern that many people, and the minister speaks to the model of UPCCs as focused on episodic care, and perhaps attachment isn't the primary goal, but when people line up, many of them are looking for a family physician. They want to be connected to a physician so they can have the longitudinal care that they need and deserve. So, tough question, but does the minister believe that the investment that's been made in a model that often results for people in people waiting for a long period of time, not necessarily ending up with an attachment to a family physician, should that continue to be a priority when we look at cost, effectiveness? And I'm wondering that, and I'll tie this in so that we can, I thought we had a good discussion yesterday about community health centers and the value that they provide. They are community driven. They're very individualized in terms of how they operate. Has the minister, taken a look at, okay, we created UPCCs. Has there been any thought to, should we be shifting more to the community health center model? So I guess I just want to sense that there's an ongoing evaluation, that effectiveness, cost effectiveness, most importantly, results for patients, that's all weighed and considered without, and I use the word, minister doesn't have to rise up here, but stubbornly headed in one direction when in fact we need to look at the outcomes and consider whether or not there are other ways to better meet the needs of patients.
Minister.
I think appreciate the question. So, because it's absolutely legitimate, it is a significant public investment. And I would say what I said in answer to the previous question. First of all, the doors have been open of UPCCs. And so some of that lineup is people wanting to see a physician or a nurse practitioner in person. And we've gone through a period where we went for the overwhelming number of doctor's visits from in-person visits to virtual visits. And for some people, that hasn't worked very well. And we're working that issue through with the doctors of BC, this issue of virtual visits. Like we were whatever we were, 90-10, and then we went to 30-70 the other way because of COVID, and now we're sort of 62-38 or 60-40, and so that's part of it. And so the UPCC being open is providing services for people who need them, and a significant portion of those people are people who have family doctors, but they want to see a doctor and a nurse practitioner, and that's what they do in the UPCC stores open. So that's a value. But I think it's similar to some of the issues in the hospital. In healthcare, things are connected, and I think we have been remarkably flexible in the approach here, given the challenges of the times. The UPCCs have a number of different models, different in Prince George than they are at REACH, which is a community health center that runs a UPCC for the government, to the one on Victoria Drive, which is Health Authority owned and operated. So the models have been different in different places. They're all team-based care, but the models of care have been different. And I think we have to learn where they've been most effective and where they weren't. I think a legitimate criticism of what we did in the Capital Regional District was too many UPCCs too quickly. I think that's a legitimate criticism. Have to acknowledge that. And they're building out the one in central downtown Victoria is now one of the largest in terms of staff. But that had an impact certainly in the beginning phase, and that affected, I think, confidence here in the UPCCs that you don't see in other communities. But what this is, there are 30 UPCCs in BC. There are about 2,000 doctors' clinics in BC. So they're a small portion of it. They're providing an important service for episodic care and connecting to the community, team-based care, providing care for people. I think it's a good model to go with. No, it's a good model to go with. The primary care network is what we spend the most money on, and it's a model that builds on the existing model of what are sometimes called patient medical homes, but are really doctors' offices or health clinics of different kinds, linking them together in a community so that the community can support one another and build out services, so that in some communities where you have mental health services, a doctor can refer someone right away. So that's the broader primary care network of which UPCCs are a part. Community health centers are another part. And there's a very significant difference in organization where it's effective of rural healthcare than urban healthcare as well. So I think we have to pursue all the models. And all of this is changed by the fundamental changes that have come in primary care with our agreements with the doctors of BC and the increase in the number of nurse practitioners as well. So all of those means, and all of that is shown, I think, demonstrated on the part of those who are leading our primary care network efforts, a lot of flexibility. So I think the UPCC model is effective. I think it's worked for people. I think we have to address the broader issues in primary care, and that's what we're seeking to do through recruitment of a lot more family doctors and nurse practitioners and have them working in family care. One of the things we've done in BC that's more effective than most places is to create opportunities for nurse practitioners in primary care. In a lot of places, they're much more used in the hospital, say in Ontario, than they are here. And so we're building out these models. So we're doing all of those different things. And there's sometimes a focus on UPCCs, as there is on walk-in clinics, which we've also got to do some work with to integrate them in a better way in the system. I think our walk-in clinics often provide really important care for people in communities, and you see the same phenomenon there as you sometimes see at UPCCs, which is that the patient capacity is reached early in the day, and then they work through that capacity in the course of the day. So I think we need it all. I think as we build out patient care and hopefully reduce the number of people unattached to a family doctor, I think the role of UPCCs will continue to be important, especially for those who don't have access, who are unattached, or who may choose not to be attached to a family doctor, but occasionally need care from the healthcare system.
Member.
Well, I appreciate that answer. I guess I look at, some of the comments that have been made about UPCCs being a stopgap, for example. And so perhaps the minister would like to tell me what his view of that is when it comes to describing a UPCC as a stopgap measure. I'm assuming it's linked to the fact that it provides a place other than an emergency room where people can get care, so they're not, being forced to visit a hospital emergency room, which the minister and I both know have faced some pretty significant challenges and continue to. So maybe just a quick comment on stopgap, what that actually means and looks like. But from my perspective, when we think about the discussions we've had over the last day, particularly, it is about access to primary care. And I think we would probably agree that there's more work to be done, and people need to better understand the integration of the system, where they fit, how they navigate their way through those pieces of the healthcare system more broadly. So maybe just a comment on stopgap, and then I'm going to move on to a question about physician attraction.
Minister.
I would say that's not the term I'd use. One of the important things that UPCCs do as well is they're open, most of them are open 365. And I think for people seeking care in communities, that's really important. It's not stopgap. to have a place that's open on a Saturday and Sunday in the community that's not the emergency room that people can go to. And I think that's a value. Most UPCCs are open well into the evening. Same issue. A lot of doctors' offices, they work very hard. They're doing all kinds of different things, but the office's hour of operation tend to be ordinary work hours, so they're useful for people. Those are not. Having a place for episodic care where people who need to see or feel they need to see a doctor for an urgent reason that day can go and get to see a doctor, a nurse practitioner, or the appropriate healthcare assistance. All of those, I think, are useful things to do. So I think, I think sometimes the criticism of the UPCC is the criticism of a broader desire for primary care to ensure people have access to a family practice doctor, and you focus on the things that are there and not the things that are not there. But what UPCCs have done is really useful. But they're one tool in the system that I think provides both an excellent level of care, team-based care, referrals and connection to the healthcare system for people who might be disconnected to that system. And of course, care for people who need to see someone for an urgent reason during the day and don't want to go to an emergency room. All of those are important roles for UPCCs. And I think in most parts of the province now, they're doing well in terms of recruitment. We've seen a real growth in the past year, and we're going to continue to see a building out of that. And a connection of that, though, importantly, to primary care networks. If the UPCCs are off to the side here and they're not connected, that's not what we want. We want UPCs to be a place people to go. And in a system that's growing, a primary care system that's growing, maybe a place that people can connect. And maybe they only go to once. That's not stopgap if they're connecting to the services they need. Those might be different services in a UPCC than another doctor's office. But if we're doing that, then we're doing they're doing their task well. But 30 on 2,000, I think the 30 should perform well, and they're really important. But we need, with primary care networks, with community health centers, with patient medical homes and doctors' offices, we need to build out a system and community that responds to patient needs, which are varied in the course of a year, maybe, in the course of a lifetime, certainly.
Member.
Thank you, Madam Chair. In November, there was an announcement related to internationally educated and trained physicians, and I'm specifically interested in the changes that the College of Physicians and Surgeons were going to make in their bylaws to allow, and this focused on U.S. Physicians. So and there were obviously there was a set of expectations about practice for that physician. Can the minister tell me how many American-trained physicians have been recruited to BC since that announcement and where they are employed?
Minister.
So thank you, Honourable Chair. Thanks to the member for the question. The amended bylaws were put in place on January 13th, 2023. So we don't have information. There's a recruitment campaign that's going to be associated with this. But the changes, the college moved quickly on that. What it does is enable American Board of Medical Specialty certified physicians with 3 years of specialty training in these following areas: emergency medicine, internal medicine, and pediatrics, to obtain restricted licenses to practice in BC. We'll try and seek more information on who's going, but this is something we can recruit behind. Because there is a significant interest from American doctors in coming here. So this creates a new pathway for 3-year trained certified physicians to apply their training and experience to practice medicine in BC without the requirement of an additional residency training that would be required for a provisional or full license. So what we're doing is allowing for this possibility, and then we can recruit behind it. This was an impediment to people coming. And so, we'll provide more information, but that's the change that was put in place. And the college said they'd put it in place in January, and they did.
Member.
Thank you, and I would look forward to an ongoing update about the effectiveness of that. And I've certainly had people contact me about people who, in fact, are living in Seattle, who are physicians, in fact, born in Canada and want to come back, so trained in the U.S. So I will be very interested in seeing what the numbers look like. I would like to move on to the issue, and it may not seem like a big thing, but it is a big thing. I'd like to talk about administrative burden and the fact that physicians are spending a doggone lot of time on administrative tasks. So I'd like to ask the minister if the ministry knows, do we track and do we know how much time physicians spend on administrative tasks in our province? And do we have an analysis? I'm going to talk about the Administrative Burdens Working Group in a minute, so I'm just asking, generally speaking, because I thought it was really interesting when the Doctors of BC talked about the cumulative impact lens on physician demands. And it's funny because when we talk about cumulative impact, it's usually in the natural resource sector or land management and planning and things like that. But they made some really important points, and one of them is, and this is a quote from their work, no single task is the ultimate cause of a problem, but when many tasks accumulate over time, significant stress is often the result. And I think what British Columbians want is to make sure that physicians are freed up wherever possible to do what they are called and trained to do. So, does the province analyze the amount of administrative work that is being done? And did, the Doctors of BC talked about using a cumulative impact lens? Has that been considered by the minister?
Minister.
Thank you very much, Honourable Chair. I think the new payment model, one of the advantages of it is there's a set aside and a recognition of that administrative burden. So for doctors working on that model, who are not all of the doctors, but they're 60% in longitudinal family practice, it's a significant change. This was a priority for us and physicians in the most recent round. So we've set up, and people sometimes smile when we say we've set up a process and a committee together, but we have, and funded it through the BC Patient Safety and Quality Council to focus on that very question of administrative burden. And the pilot projects for the first year in dealing with that are what are called special authority forms, BC cancer forms, and appointment processes for health authority facility imaging services. So those are the pilots to reduce the administrative burden in all three of those areas. In addition, the work we're doing together, I think one of the challenges a lot of physicians face is that other people are asking them to do things outside of the healthcare system that people come to them for that are essentially administrative, right? And sometimes pay extra for it. An example, I have on my driver's license, I've had at different times in the past gone to doctors, and then they have to fax to the driver's license office to allow me to continue to drive as a person with diabetes, for example. Those are the kinds of things, but there are a lot of administrative burdens. A lot of people are asking doctors to do things that are outside of the healthcare system for which they are sometimes not remunerated or not remunerated appropriately, and in any event, take a lot of time. And so we're working with them on that, but there is an absolute process. It was a key issue raised by them and by us in the Physician Master Agreement, and there's a process that is action-oriented. These are pilot projects to reduce administrative time in specific areas, and we're going to go through those, and the three that were identified first were the three that I discussed.
Member.
Thank you to the Minister. I thought the statistic from CFIB was interesting because they actually say that physicians in Canada cumulatively spend 48.8 million hours per year on administrative tasks. But the interesting part of that is that from their perspective and looking at the analysis they've done, 30.5 million hours are considered necessary, 18.5 million are unnecessary. So I can understand and appreciate that the new physician payment model compensates, but what we want them to be compensated for is necessary work. And the issue that is being, that at least as I understand it, raised by the doctors of BC is redundancy. And again, one of their recommendations did deal with third parties and trying to figure out how to limit the fact that, you know, they're asked for all kinds of things, that signatures and all of those things. So I'm glad to hear that work is being done. And I'm glad to hear that it is a priority, because that is not where we want our healthcare professionals spending their time. What's necessary, absolutely, but let's get rid of the unnecessary. So there was a memorandum of agreement that was created to deal with this issue, the Administrative Burdens Working Group. And terms of reference was to be developed following the Physician Master Agreement. So I'm wondering if the group has met. If so, who are the members of the working group, and how often? Maybe an update on that Administrative Burdens Working Group. Has it met? Who's involved with it? How often do they meet? So let's just start with that.
Minister.
So I'll share with I'm going to get a copy of the list of the membership, shared by the Patient Safety and Quality Council as suggested. The three items that were the first priorities were suggested by the doctors of BC, so those were particular items. So this is a very concrete and practical process to deal with specific items that were causing administrative burden. I think one of the challenges with the fee-for-service system has been, one of the frustrations is that often we've done good things to increase the complexity of the system. Sometimes special areas of treatment, go back to diabetes or whatever, where we're attempting to use fee-for-service to appropriately compensate doctors. And sometimes the additional burden of dealing with new codes has been in place. And that's why the goal has been to reduce fee codes in this PMA process, working with the doctors of BC. And this committee has been set up under the auspices of the Patient Safety and Quality Council. Its priorities have been identified for the first year. It has a budget, and it's acting. And I'll be happy to share the membership. I can just provide the member with that on paper.
Member.
All right. I may have missed it, but so is the working group called the Administrative Burdens Working Group? That was the memorandum of understanding that was signed. And one of the things that, and I'm Minister anticipated one of my questions. I was going to ask about funding, but this group obviously has a budget. It will meet regularly. That physicians would obviously have the opportunity to bring items to. So one of the specific suggestions, at least for a one-year pilot, were to actually look at specified forms and processes that create administrative burdens. So is that part of the work that's being done? Is making sure we're looking at, the reams of paperwork that needs to be done, and then how, as I understand it, there will be recommendations coming back from this working group that would, I'm assuming, come to the Ministry of Health and the Doctors of BC. But could the minister just confirm what is the process for actually making change? And is there a focus on literally specific tasks and forms in order to identify what might be redundant or unnecessary?
Minister.
Yes, in the specific form. So the funding's in place. I'll just say that the co-chairs are Leanna Silver from the Ministry of Health and Rob Hullock from the Doctors of BC, that there is a budget in place, and it's a very practical thing. The Doctors of BC identified the three types of forms of administrative burdens that they wanted focused on first, so that came from them. And so that's going to be very practical. So it's not going to be a catch-all for everything. We want to focus on things, resolve them, and then move on to further issues over time. So those are, as I noted, the special authority forms, the BC cancer forms, and the appointment processes for health authority facility imaging, which are important considerations. Again, not identified in that case by the Ministry of Health, but by the Doctors of BC in that consultation. So the work's begun. It's very focused in a very concrete way on specific problems, and it has excellent co-chairs and is under the auspices of the Patient Safety and Quality Council.
Member.
Thank you. Will there be a public reporting out so that there is a sense that we know the work's been done and what it's accomplished?
Minister.
So the reports would go to the Physician Services Committee, which is joint ministry Doctors of BC. And so it could be, it's public in that sense with the Doctors of BC and the process, since many of these issues but it could be easily shared publicly as well. There'd be no reason not to share it publicly. And I think what we want to show, obviously, is progress on that, and it would be communicated. It would have to be communicated to everyone who's a doctor in British Columbia.
Member.
Thank you to the minister for that update. I think that again, it's part of the process of, I guess it's in essence red tape reduction. It's trying to get rid of the things that are redundant or unnecessary, so people can focus on the things that they really need to be doing. I want to move to practice ready assessment, if we could please. Again, still focusing on primary care, but I'm wondering if the ministry has already increased the practice ready assessment seats to 48, and are those seats full?
The process is going stepwise. So the goal is for March 24 to get to 96. So it's 32 now. This spring it'll be 41 in the first step, and it'll go step by step up to 96. And progress is being made. We already have the confirmation of many candidates. Of course, from fall of 2023, we're in the process now. So it'll be 41 this spring, and then it'll build up to 96 by March of 2024.
Member.
Okay, I'm wondering if the minister could just go over those numbers again. I think I'm hearing is that we're increasing the intake. Are all of those seats full? And so if he could just walk through the incremental numbers again. And I'm wondering if the minister can assure me that the program has the necessary supervision capacity to take on a substantive expansion.
Minister.
So there's first of all, there's an active management process as we build out. We're increasing capacity. That means finding more preceptors, and that process is happening now. It's on track. We're on track in terms of recruits coming into the program. And we feel confident, although it's challenging. Remember, for some people to come, sometimes you're working a year in advance for someone to come who's coming to the country to work through all the immigration challenges that they face. But we're confident about the 41. I want to say about the 96, though, and this is important, that right now 16 are reserved for rural areas of the 32. Those 16 will continue to be reserved, but we'll have 80, and some more of those will clearly go to rural communities as well. But I think the idea is to maintain that base, because the focus of half of the program has been on rural communities. And if you look at where people coming through the PRA program have been, you see communities in every part of the province. In fact, 59 different communities have welcomed physicians from the PRA program. So the 28% increase is this spring from 32 to 41. That's 9. And then we build up through to next year when we expand to 96 seats by March of 24. That work is being done in an organized way to make sure that they have the supports and the preceptors in place to make that happen. And obviously, there's a lot of interest amongst communities of doctors from international medical graduates around the world.
Recognizing the member of Prince George Valmont.
Good afternoon, Honourable Chair. Thank you for that. Can the minister identify for me what new funding is in the budget to facilitate the tripling of the Practice Ready Assessment Program?
Minister of Health.
Thank you very much, Honourable Chair. Good to see you. In terms of the fiscal years, to say to the Honourable Member, that's 3.42 million in 23, 6.94 million in the, so that's 23-24, I should say. 6.94 million in 24-25, 7.13 million in 25-26. So you see it building out as we build out the positions in the program. That's a combined 17.4 million over 3 years.
Member.
Shift change.
Thank you very much. It is shift change, yes. I was thinking exactly the same thing. So I want to move on and spend some time on the Health Human Resources Strategy. And I'm going to begin by just asking some specific questions, and then I'm going to invite my colleague, who is the Shadow Minister for Post-Secondary Education and Training, to ask the Minister some questions as well. So I want to begin with by asking if a provincial working group, it's a shift change of the public service as well. So are we ready? Okay, good. At least we're all in the same room together today, so that is a definite upgrade for us. Has a provincial working group been established? Has the provincial working group established key performance indicators for monitoring the health sector workforce? And there are 4 categories laid out in the Human Resources Strategy: retain, redesign, recruit, and train. So let's start with just the basic question. Have key performance indicators for monitoring the health sector workforce in those categories been laid out?
Minister.
So thank you very much, Honourable Chair. So the Health Human Resources Plan has 70 actions, and so many of those have been acted on, and in the sense that announcements have been made, actions have been taken by the government. There was a commitment when we tabled the plan to an annual reporting, and since the plan was tabled in the last week of September, I think it was September 29th, the first report on that plan will be annual to that, on all the recommendations. We have a government structure, which is called the Provincial Health Human Resources Coordination Center, PHHRCC. Got that? And that has on it, and as part of it, the Leadership Council, which is the senior leadership group in healthcare chaired by the Deputy Minister of Health, Mr. Brown, and involving all of the CEOs of the health authorities. And then there's a coordination center that is driving this initiative. So those are, that's the broad governance and implementation, and we'll see the results of that. Obviously, there are other places where we see results. We saw the results from the Canadian Institute for Health Information, but we'll be reporting annually on the results of the plan. And obviously, internal to government, there will be an accounting to Treasury Board and Finance around the expenditure of money against those priorities as well, which is the normal process. The member is a former Minister of Finance, so she knows about all those things, and a member of Treasury Board, so she knows that that process is in place. But the public-facing report will be annual, and the first one will be from 1 year from the announcement of it, and it'll be a report on the recommendations, what's been implemented, what progress has been made. So we can expect that on or around September 29th of this coming year.
Member.
Well, thank you, and I appreciate it. I think an annual report is important, but when you look at the report itself, on page 63, it says that a clear and transparent evaluation framework is key to assessing and demonstrating the impact of programs. So to me, that sounds a lot more explicit than an annual report. It speaks to the need, in my view, of being able to measure success and the impact of each of the objectives that are laid out in the plan. So my question is there an evaluation framework, and will that, first of all, be made public? And are there specific targets set for each of the objectives?
Minister.
So the purpose of the annual review is to report against the 4 categories. So all of them, including redesign. We discussed pharmacists earlier, and we may again. That's an example of a redesign proposal. And so, and the governance structure is to drive these 70 actions, many of which have been specifically announced. So things such as retention incentives, wage leveling, which has been completed, changes on associate physicians, we may have occasion to do that, the change in pharmacy, the change in emergency management, scope of practice. Some of those changes are, in some cases, almost completed. And the ones around retention that include, let's say, retention incentives, that have been put in place, but also the relational security officers and the hiring and what we're doing against the announcement and the measurement we have. So we will measure in detail both against the 4 priorities or the 4 areas and also specifically against the 70 actions.
Member.
Well, thank you to the minister. I guess from my perspective, it's one thing to put out a report with dozens of recommendations. It's another thing to measure and report progress. And British Columbians need to have a sense of confidence that the government understands the demand and has a plan in place to actually deal with that. So perhaps I'm trying to think of how, so the minister has, I think, told me that there obviously some of the recommendations, some of the actions have been taken care of because they were one time, in essence. I'm just concerned that we need to know whether or not the plan is working or not. And the way we do that is by measuring, setting objectives, targets, and reporting out, holding ourselves accountable for those outcomes. So I will leave it at that. I'm hoping the minister can either verify that that is the process that will be undertaken. I guess I'm a bit surprised. I mean, when I think about it, there is, I'm sure the ministry has a matrix with a very long list of every single thing that was committed to, and that they will be tracking where they are on completion of that particular action. So from my perspective, the next step is let's be transparent about that. Here's what we said we would do. Here's where we are at with it. Here are the gaps. Here are the challenges. So maybe the minister can tell me if that's how the process is working. In the strategy itself, and I quote, the demand for health services will grow by 14% over the next decade, and that, again, a quote, current baseline staffing issues will be further aggravated. So, and this will probably lead to some of the questions that my colleague has, but so does the ministry have estimates by profession of what we need over the next decade?
Minister.
We do forecasting, of course, and as we know, the number of healthcare workers has increased dramatically in the last 5 years. And we see in the CIHI reports how well we're doing in the key areas against other jurisdictions. Doesn't mean we don't need to do better, it just means that. But I think the member talked about the kind of very specific accountability we're talking about. Give an example. And because it's an important one and people are asking questions about it, we laid out a plan over a period of a little over a year to change the security model. It was a key advocacy of the HEU, of the BCNU, of the HSA, and a lot of people working in healthcare, and the member has heard it as well, all of the issues around code whites and other things. So we said we were going to change and implement a relational security model. So at 14 sites, 13 leads have been hired. All 320 relational security officer positions have been posted. They're all going through the posting positions, so that they've all been posted to put in place, and they've all been posted through the different health authorities. So Interior Health, 7 sites, 80 positions posted. Northern Health, 40 positions posted, 30 in Providence, 20 in PHSA, 35 in Vancouver Coastal, for example, 95 in Fraser, 20 in Island Health. So we'll be reporting that they've been posted, that people have been hired against that, and that what the progress is made on the, so we have the leads now in place, which is critical. That's where you start. 13 or 14 hired. So that's the kind of specific on, that's one action. That's action number 3 that's involved in retention. In terms of retention assistance, we have the specific incentives, I should say, number of recipients in specific regions that are in numbers, and we've discussed these numbers already, so I won't go through that again. For example, on wage leveling, which is item 9, that's been implemented and complete in long-term care and in assisted living. Nurse-to-patient ratios, which is a key element of workload standards, which is action 18. It's in progress and obviously pending, in part, the vote tomorrow. And we go through on pharmacy workforce optimization. We made changes in October that have added, in terms of prescription modifications, about 32,000 a month. That's a rate of 360,000 a year. And so we'd be reporting very specifically on that, and on the prescribing for minor ailments proposal, and then how that's taken up and so on. So these are very specific actions. They're not recommendations, they're actions. And so we'll be, in each case, assessed in that way. On different issues like training spaces and filled training spaces, that's a different measure than it is when you're hiring 320 security officers, but each item will have a different measurement because they're different, but all of them will be measured, and it's the job of the implementation committee to drive that.
Member.
Thank you, Honourable Chair. So there will be specific monitoring of specific vacancies, and that will be part of regular reporting, I think is what the Minister just said. Are those vacancies, are they tracked in terms of nursing? Are those broken down by position, emergency room physicians, and other critical areas? So what I would appreciate the Minister sharing with me, and he doesn't have to do it by reading it out loud, if he could share any data that he's able to share that is broken down by health authority that provides us with a sense of what the vacancies are. But perhaps he can just outline for me, are the vacancies broken down by critical areas, emergency room physicians, nursing, etc.?
Minister.
So just to give the member a sense and provide more information, so I don't do a long list, but the areas where we have the highest levels of vacancies, so the professions, licensed practical nurses, medical laboratory technologists, that's key in a lot of community, nurse practitioners. We're growing that out very significantly in terms of training, but that's a place, occupational therapists, and interestingly, social workers. So those are some of the professions that have the highest vacancies in the province. Vacancies in an overall sense, and this won't be a surprise to the Minister, are highest in the Northern Health Authority and lowest in Fraser Health. But that doesn't mean in Fraser Health there aren't significant staffing concerns. So those are some of the areas, if you want, the areas right now. That may well change over time. And part of the challenge in the healthcare system is we are building out a system of mental health and addictions care and other things which will create new positions, which then increase the human resource demand. So we've added net 38,000 positions. We're leading Canada over the last 5 years in the rate of growth of registered nurses, of nurse practitioners, of LPNs and others, and other groups we've been leading. But that doesn't mean there isn't consistent and increasing demand. So on these actions, just to give an example just of another one, and I won't go through a lengthy list because we've got lots of questions. I know we'll hear from the member from Cariboo North as well on some of this, but on internationally educated nurses, these are answers I gave before, so I won't go through all of them, but we talked about the return of service sign, that's 2,550. And then the applications that have come in, we have assessments completed, and that's on that item, which is item number 36 in the plan. That's what's measured, right? How many have been hired? I said yesterday that was 160 IENs and 64 internationally educated nurses, and internationally educated healthcare assistants, I should say, hired since the new pathway was launched. So that's the detail of the measurement. We said we'd do this. How is it working? How are we getting through? How many applications are we receiving, and who's been hired? So those are the measurements. So, for example, for action item 36 in the proposal in the plan.
Member.
Thank you to the Minister for that response. I think what people are longing to see that work in the healthcare system is some form of stabilization. You stop and think about it for a moment. Healthcare workers are constantly overworked. There is a great deal of stress. In fact, and I know the Minister has heard it, and I have heard it firsthand from people, and I'll speak to it specifically when we get to specialist access in a few minutes, but people are actually using the phrase moral distress. And one of the things, and the reason for that is that they can't, in the current circumstances, they can't provide the level of care that they want to, that they are called to. That is what they do. And so I guess, can the Minister speak to what are the kinds of targeted outcomes for the stabilization of BC's healthcare sector? The workforce needs to have a sense of confidence that the sort of crisis management that has to take place will at some point be stabilized, so they can, have a more normal approach to their practice. So, not and I know the minister can list off a number of things in the document, but I just wanted to be on the record in terms of talking about stabilizing the system. That's what we need to do. There is a deep sense of distress, and so I'm wondering, what is it going to take? How much longer are people going to have to feel like the system is in crisis? And what are the specific resources within the next fiscal year? How are we going to move toward a more stable healthcare system?
Minister.
I think one of the value of having the Health Human Resources Plan in place and then driving 70 actions is that people, I think, doctors and nurses, in all categories of nurses, healthcare workers, health sciences professionals, ambulance paramedics, see themselves reflected in the work being done on that plan. So on primary care, we've discussed the elements of that and really the success so far. And you see that doctors see themselves reflected in the plan by the fact that they're adopting it in such remarkable numbers so far. Doesn't mean there won't be challenges, but what they talk to us about as being their priorities, we worked with them to address. And you add to that, in all categories, the efforts to bring in internationally educated doctors and nurses, increase training spaces in all categories, and all the efforts on retention. With respect to nurses, we of course have added the training spaces. We need to do that. And when we add training spaces, nurses stay in BC. This is true of physicians, it's true of nurses as well. We've added those training spaces to provide hope, the pathways for internationally educated nurses, and also a collective agreement process. And again, nurses are voting on this, that provides both a sense of stability and reflects their contribution. I think nurses will see themselves reflected in the priorities that have been given to nursing in this area. And in fact, if you look at it from 2017 to the present, you see that we have seen net new in registered nurses. We've grown the fastest in the country. We got to continue to do that. And that's what that does for health sciences professionals equally. The Health Sciences Association, Professional Bargaining Association has increased by 26% over the period since I've been Minister of Health. And we've got a lot more work to do. And so we're doing the same work in that area. The work with ambulance paramedics, I think, which was reflected in their response as workers, because I think, and we've talked about this in the House, the member from Prince George Valemount, but not just the member for Prince George Valemount, other members of the opposition around ambulance paramedics. We worked with them on a model both of recruitment and stabilization that's moving that system from a casual system to a permanent system. And the work we did, which wasn't just collective bargaining work, but which system work with ambulance paramedics, resulted in a 96% ratification, which is, if you know ambulance paramedics as I do, is a pretty remarkable thing on a group that's actually quite diverse in terms of permanent full-time, permanent part-time, and casual workforce. To have that level of support for that effort is significant. Equally, for healthcare and healthcare workers and assistants, the getting rid of Bill 29, the repatriation of healthcare workers, the HCAP program, which has been phenomenally successful, its expansion to home support with 900 home support workers, all of those things are intended to drive stability and confidence of the public, but of healthcare workers in the system. And they reflect what healthcare workers have and healthcare professionals have been asking us for. So I think as I meet with healthcare workers and healthcare professionals across the province, these are the things they've been asking for on the recruitment side, on the retention side, on the training side, and on the redesign side. And I think that pharmacists, I'll just say finally, because this is one area and talked about too much, but pharmacists see in these changes as well, and the public will see in these changes, a recognition of their role, not just as the leaders of a vaccination program that saved, let's face it, tens of thousands of lives in this province, not just pharmacists, but they were key leaders in it, but increasing their scope of practice and allowing them to work to the full extent of their practice. And others will see that as well. People coming into the system, the licensing of associate doctors, which is significant in the system, and all the work that has been done on scope of practice issues across the system. So I'm hopeful, and I'm going to limit this to 5 minutes, this response, because it was a significant question I think the member was asking. That is a reflection in the Health Human Resources Plan, a reflection of the priorities of the public, but also of healthcare workers. And I think that on the actions we're taking, they're showing that success, and we got to continue to work really hard, because we need to do what we've done in the last 5 years and the next 5 years, which is to add net new tens of thousands of healthcare workers and professionals to the system.
Member.
Thank you to the Minister for that. One of the things that I hear regularly, and I have very much come to believe, that we talk a lot about recruitment and training, and those are all essential. But right now, we need to focus on retaining the incredible people that are in our system. And many of them, and the Minister knows, there have been surveys done where a large number of our healthcare professionals are contemplating leaving because of the impacts of COVID on their personal lives. And one of the things we have to do is make sure that we are taking care of our healthcare workers. And I was appreciative of seeing that in the strategy, but it has to start with caring for the people who care for others. And that's how we're going to retain them. So I will just ask this question very quickly. Has the Provincial Health Workforce Wellness Team been created?
Minister.
Just in terms of the overall, because just to give a sense of the priority on all of these initiatives. So it's $324.9 million in retention, which is to build healthy, safe, and inspired workplaces. If you look at the overall budget, the $955 million over 3 years to support the 70 action of the plan. So this is the proportion in the category. So it's 324.9 on retention, 193.9 million on redesign, $224 million on recruitment, and $323 million on training. So when we say those are the 4 priorities, we mean that. They're all significant, and that shares those priorities. You can see in the partnerships under recommendation number 4, action number 4, the increased support for healthcare worker wellness, the supports that are going on for the Care for Caregivers and the Care to Speak programs. In addition, specifically, the money allocated to physician wellness in our agreement with physicians, the money allocated specifically under the nurses agreement, and again, they're voting on it, but specifically for nurse wellness, which is important for supports for nurses. And the provincial health workforce wellness team hasn't been established yet, but these are elements of it, and it will be established shortly. But there's specific items, and we could say the same thing for the Health Sciences Association agreements and for the Facilities Bargaining Association agreement, which is predominantly HEU. So all of those elements are part of the work we're trying to do, because as we've said, and we talked about Action 3, which is the change in security, that's important for nurse wellness. The specific elements of these collective agreements that are focused on mental health supports and wellness, that is a key part of the action we're taking. So retention, the member is right, and it's reflected in the priority given to retention throughout the Health Human Resources Plan, and it is in fact of the 4 initiatives the one we're investing the most money in, creating healthy workplaces, because obviously creating those workplaces assists in all of the others as well. It's great to have recruitment programs, but the retention programs mean that the recruitment programs, when they succeed, stick. And that's what we're trying to do. We've seen the positive impact of that in the healthcare assistant program, the net impact of that on numbers, but across the system, those are the priorities. So that's how we provide priority across the 70 actions. Retention is the largest of the 4, just slightly over training, but it's the largest of the 4 priorities.
Member.
Thank you to the minister. And I guess this goes back to my earlier question, because I'm not only interested in the workforce wellness group, which is new, from one of the things that there needs to be a sense of urgency, and I'm not suggesting the minister doesn't get how important it is, but we need to move quickly to provide the supports if we want to retain people. People are considering leaving. And when you think about announcing a workforce, wellness, we also have peer mentoring, and that in fact people will be hired to initiate those things. So I guess my ultimate question is there an implementation schedule we started here and we're going back there, for each one of these actions, so that people have a sense of when we're going to see those committees, when will peer mentoring be in place, so that there is a sense of urgency about caring for people in healthcare who many of them are experiencing moral distress.
Minister.
And the one item in addition I wanted to note is the creation of Switch BC, which focuses on occupational health and safety of healthcare workers. It's led by healthcare workers. There was an agency that was in place. It was eliminated approximately 14 years ago, and it's now been reinstated under the Societies Act. It's in place. It has a CEO. It's a key aspect of the relational security model, is counting on them to drive that. So that's something that we said would be in place. It's in place. It's directed by healthcare workers and not by the government, but obviously we provided $8.5 million in funding to support its establishment. That's just one example of the actions that are taken, and there's a series of others. So yes, there is urgency here. And if you look at what's happened in the last number of years, I mean, we had the COVID-19 pandemic, all of the changes that occurred directly after that, the urgency that went into those changes continues to see, and we've seen these very significant reforms in primary care for doctors, support for doctors. The nurse agreement is, I think, a landmark agreement in Canada. I'm hopeful, again, that about the vote tomorrow, and we'll perhaps have that, we'll probably have that while we're still in estimates, and all of the change we've made with health sciences professionals and others. So yes, there is urgency. The scope of reform is remarkable. And I think some people felt that we'd be returning to silos as we evolved into this phase of the COVID-19 pandemic and the other challenges facing the system. That is the opposite of what's happened. I'd argue that there is more desire from healthcare workers and healthcare professions for change, and seeing that change happens deals with issues of distress that many are feeling.
Member.
Well, thank you. And what I would be relieved to see is a chart that lays out all of the announcements with an implementation strategy, plan, date, outcomes, and measurements attached to it. So I look forward to seeing that or being made aware of what that looks like, because it is one thing to make an announcement and roll out a document. What really matters right now is how we are responding on the ground to support people. And the report itself talks about some of the key things that are needed. Ensure a balanced workload. I think if you spoke to many people in the healthcare system this afternoon, they would not feel their workload is balanced. We are post-pandemic, but we are not post the critical issues that people are feeling from a personal perspective. And one of the things the report repeats numerous times is we need sufficient people to care for patients and co-workers alike. So I want to urge the minister to look at those initiatives that are linked directly to retention so that we can work to keep the people who have served us beyond measure over the last number of years in particular, and prior to that as well. My last question, before we sort of link the need to understand vacancies and what the future looks like, and the training plans and strategies, can the minister speak to the issue of the representation of women in health sector management? Whether he's concerned about that, whether there are initiatives in place to look at that. And one of the things I would be very interested in knowing is what is being done to eliminate a gender pay gap in terms of healthcare overall.
Minister.
Well, first of all, recommendation number 13 of the plan hardwires a gender-based analysis in the plan, in every element of the plan. Let's say a few things. I would say all of our regional health, no problem. All of our regional health authority CEOs are women. Majority of our management are women, and I think they're remarkable, and you're seeing that increasingly through the professions. Obviously, a majority, that's good because a majority of our workforce are women. I believe the majority of younger doctors, for example, if you look at physician workforce, are women, and that needs to be reflected. So in every aspect of what we're doing, that gender-based analysis is in place. Obviously, significant work is done broadly and across government in that, but that's a core element of what we do as well. And we have, and I think that's a reflection. I think it's more than symbolic, and this is important in also the way that we appoint health authority boards. which are majority women. I believe, look across our 6 boards, I think 3 of our board chairs are women and 3 are men. But in terms of our membership, a majority of women are as well. And this is important beyond that in other representation as well. One of the things I'm proudest of about our pandemic response was the central role played by the First Nations Health Authority. We have a leadership council in healthcare. The First Nations Health Authority is integrated with all of them. They're at every meeting that we have, every meeting in pandemic response, both at the provincial health officer level or at the CEO level has involved that. Every health authority has at least, and in some cases more, 2 Indigenous members on it. So across what we're trying to do, that issue of both representation and involvement is critically important. But the member is right. That is critical to our success as well, whether it's in efforts to ensure that younger doctors, and this is seen and reflected in the new payment model for family practice, reflects and creates flexibility for younger women doctors and all of the efforts we need to do to ensure that people have the opportunity to achieve leadership positions in the system. So all of that's in place, and obviously all of the actions we've taken in terms of the repatriation of healthcare workers, majority women, in terms of supporting and dealing with Bill 29, and then wage leveling, majority women. All of these actions are embedded in all of our actions under the Health Human Resources Plan, but they're critically important that our healthcare system reflect people in society. And I think at some point later, remember, we'll be discussing the In Plain Sight report, so I won't get into those aspects of it, but all of that is critically important as well to healthcare outcomes. Sexism and racism are bad for your health, and we have to target them in every possible way in the system.
Recognizing a member for Caribou North.
Thank you very much, Mr. Chair. Our success in all of this depends on our students and the confidence that our students have in the systems that we have in place. I do want to enter, I said I would raise it. We met with the UBC Political Advocacy Committee. I know that you were in estimates, so I committed to raise it here and table it. And it's 86,000 and counting, calling on the province of British Columbia to address elective surgical wait times in BC. They spent 7 months working on this very important report with lots of recommendations. So I just wanted to draw the minister's attention. To follow up on my colleagues' questions around the human resource strategy and how we are measuring outcomes and looking at net new healthcare workers, training is going to be a considerable part of that. And I have been working across the province and listening to a lot of students and to identify, it's wonderful that we're announcing all of these training seats, critically important to this strategy. But the piece that I think when we're looking at indicators is the enrollment numbers. And I think I'm glad that the Minister of Post-Secondary Education is in the room, because I want to ensure that there isn't a disconnect, that there is a significant amount of work being done on making sure seats exist, but making sure that the Minister of Post-Secondary Education is looking at enrollment numbers and making sure that there is that alignment. And if there are issues, for example, in Northern Health, in the training seats, we know that enrollment numbers are down. And that is a critical issue for the success of this strategy. What we've heard from specifically the nursing on the training side is we want a consistent provincial curriculum. There needs to be better transitioning from bridging from LPN to RN, that the LPN Access Program in British Columbia provides no credit for work experience, whereas Athabasca does. And so we are losing a lot of our students to go to Alberta because there is some of those training credits provided for work experience. I think that's critically important. We understand that. Loan forgiveness, that there is a lot of competition across the country from a training perspective. And I would say that a lot of the students are deciding not to stay in BC because they can access programs elsewhere. And it may be a factor in why our enrollment numbers are down. And so through you, Mr. Chair, to the minister, when we look at enrollment numbers, what is the relationship between the Ministry of Health and the Ministry of Post-Secondary Education to ensure that there's an alignment?
Minister.
So there is strong alignment between the two ministries. I'll give an example that's practical because on a practical example of success, I think the HCAP program has been the most successful human resources program the province has ever done. When we had to stand up in a pandemic and address major demand for healthcare assistance, there were different standards throughout the province. So the bi-weekly meetings between senior official of my ministry and the ministry that's led my colleague, the Minister for Post-Secondary, responsible for post-secondary education, helped arrange it. So we leveled that off so we could do the training throughout the province, which led to enormous success, more than 7,000 additional positions on both the infection control side and the 54 additional positions under HCAP, which included healthcare assistant positions in community for home support and in long-term care. It was a remarkable success, and it involved that key alignment of the Ministry of Post-Secondary Education, which drives a lot of the training, and the Ministry of Health. So that work is continuing, and we do that on an active basis every 2 weeks in order to ensure that those issues are addressed. There's a bursary that's been put in place for people making the transition. I know the member was referring to LPN to RN. I think that from healthcare assistant to LPN, which is also a really critical area because we really need LPNs, and we also need to provide opportunities to healthcare assistants to make that move to ladder in that level. And so a bursary was created, the Access to Practical Nursing program, which is a 12-month full-time bursary or a 24-month part-time bursary against a return of service agreement. And that's part of our Action 57 around bursary. So that comes out of the work that's been done and the clear alignment between healthcare and the ministry, which the member's responsible for as a critic. So that alignment is key. So as issues develop, including issues around perhaps under enrollment in particular programs, we can address those. Obviously, it's my colleague that will be, to the member will provide those clear and practical questions within her ministry. But but we're connected closely to that because some of that is about work experience, and that certainly was the case in the HCAP program. So that area demonstrates it's an area of success and shows how working together makes sense. It's not a health program or a post-secondary program. It's a combination. There's currently a wait list for all nursing programs, and so that tells us perhaps, and will tell us perhaps, that even though we've added 602 nursing spaces, that we're going to need to add more because there's a potential there. And we know, and I think what the member said about Athabasca is important, that BC is the desired place for people to come to work. And it's a real source of pride for our province that in all sectors, we are net beneficiaries. So in terms of doctor training, 80% of those trained in BC stay in BC. That number for Alberta is 61%. Trained in Alberta stay in Alberta. 20% of those doctors trained in Alberta come to BC. We welcome them. That seems good to me. And 8% of those trained in BC go to Alberta. That's in the nature of things. People will live in different places in the country. So that's in the nature of things. But we're net beneficiaries of that change, and that's a system change. But that work, that alignment is a clear part of everything we do, and it reflects the work that that ministry does with my ministry, and that minister does with me.
Member.
Much through you, Mr. Chair. I appreciate the member's comments about there's a waiting list for nurses across the province. Through you, Mr. Chair, does the minister have any comments of why on April 8th that the folks of Okanagan College faculty, staff, the community were stunned to learn that they're losing their nursing program?
Minister.
Well, there was an amalgamation, as the member knows, at UBC Okanagan. And so everyone got spaces there. All the staff have been offered employment and will be using the capacity at Okanagan College to advance allied health education. So that's not a loss of any spaces at all. And it's a practical decision that was made under the leadership of my colleague. I'm sure the member will have more questions for that. When her estimates come shortly, I can say I can't wait because I so enjoy the estimates process myself. I sometimes wish it would never end. And my colleagues do not agree. I don't think I'd win a vote on that in this room, but I'm a fan.
Member.
Thank you very much, Mr. Chair, and I will have lots of questions when we head into estimates. Just wanted to put that as a marker here because of the cross ministries. I'm going to go to a personal in the community. The minister has talked about Dunrovin in the past, and I always appreciate the ability to come and bring forward questions because I think ultimately we want solutions in the community. I do want to raise concerns that has been brought forward by multiple people in my community around the skyrocketing use of agency nurses, and that in the experience of Dunrovin, the only casual at Dunrovin has recently she's resigned because her income has dropped significantly. So what we've seen as a significant increase in agency nurses, and that has dramatically impacted nurses that are in my community that have worked and have built relationships with the clients for many, many years. And so we are worried in our community that we're actually going to be losing the nurses that exist in our community because of the agency nurses. We're very appreciative of the work that they're doing and coming in to support, especially during, the emergency. Now, as we move into what the next phase is, we do not want to lose any nurse in a community. As a rural community, that is even more difficult. And what we've also heard from our nurses is that that agency nurses are coming in and they don't have to pay their so our nurses get half the income. They still have to pay all of their fees and their dues, and yet we're bringing in agency nurses and they don't have all those costs. So through you, Mr. Chair, our community is very concerned and would like to raise that to the minister.
Minister.
Thank you for raising those issues. It's always important. It's one of the reasons I value this process, but also the work we do all the time. The member, as members will know, raises issues about Quesnel with me on a regular basis, not just Quesnel. I know her constituency is larger than that, but Quesnel is important. And what happens at Baker is important. What happens at Dunroven is important. And so I appreciate that. Here's what I would say to the member. That agency nursing is 1.4% of nursing hours. There's a lot of nursing hours, so that's not a small number, 1.4%. I don't say it's small. It's higher in Northern Health, where Dunroven is. It's higher than that in Northern Health. It was closer to 8%, and that's a lot of agency nursing. One of the major purposes of the BCNU negotiations was to value our permanent workforce, our permanent full-time and part-time nursing workforce has to be given priority. It's important for the stability, especially in communities of the size of Quesnel, but smaller communities as well, which face sometimes even more pressure when they lose a single employee. That can be critical to them in providing care. The Dunroven Lodge has benefited significantly from the HCAP program for the very reasons I described. That's nursing as healthcare assistance, but that's important in long-term care in particular. So I absolutely appreciate that. That's why we were so focused on that during the discussions with the BCNU, because it's a priority for nurses in places such as Quesnel, in places such as Prince George and Quesnel, and places in the Northern Health Authority. That was a particular priority of our discussions with the BCNU, was to address that very question, because we surely have to make the incentives right for longtime nurses who are, we can talk about new nurses, and they're so important, and we've got to recruit them, and we've got to make that work, but our longtime workers, ensuring they're retained and valued in the system was a priority for the BCNU and a priority for us. And it was, of course, the whole province in mind, but it's exactly communities like Quesnel that we had in mind. We did also increase urgency nurses. I had this discussion in more length, and I'm trying to shorten today my answers. I'm trying to shorten them a little bit with a member from Prince George Mount Robson, but just around the COVID-19 pandemic, we used more agency nurses because we had to keep all our nursing staff in place and add resources for things such as contact tracing and on over time. We're now at a different phase of that pandemic. It's not gone away, but a different phase of it. But this, part of our focus of this agreement was exactly what the honourable member is raising, and she's hearing from nurses in community, which is responding to those needs, but also valuing our longtime nurses who deserve our support.
Member.
Thank you very much, Honourable Chair. My last question is when we talk about recent graduates of specifically our nursing program and making sure that we invest in our students, and we want to ensure that they have success. And we've certainly, over the last few years, another indicator that I think we need to measure is, are we retaining our students, they graduate, are we retaining them? And what does that number look like? And one of the things that has been raised to me by both students and from trainers is that we've seen a shift, specifically in Northern Health, that there has been a cut in the education budget, and it has moved from we used to have educators on the floor in hospitals, and that was a really important support for both students that are recently graduated but as part of the training one, and it's moved to a regional training program, which is not embedded in the hospital, and that has been a significant concern raised by both students and graduates.
Minister.
And this was a key item in the collective agreement. And again, we've been talking about this. It's not yet been ratified, although we'll hear tomorrow, for that. But that issue of clinical education on the floor was a key aspect and is addressed in that agreement. Was the member is quite right that one of the challenges that happens in an unbelievably busy workplace like Baker, like Royal Inland, like University Hospital of Northern BC, like long-term care, is that support for new nurses as they come in and it's critical that be in place, and that's was a priority for us in those discussions and for the BCNU, was how we ensure that people come in, we recruit them, we do all this effort, internationally educated, coming through our training systems. We want to make sure that they're supported when they get there. And the challenge for existing nurses who have that on the floor, have new nurses who are not as experienced. And this is not just the case the way in health, but in education and other areas, like new teachers and the supports that we're providing for them in a community such as Surrey, where we have a lot of new teachers, and making sure we're supporting and retaining and supporting them as they go through their early years in that profession. But in healthcare, it's been a significant part. The issue the member raises was one that's raised by nurses in her community and communities across BC, which is how we retain and support. And that issue of clinical education was specifically dealt with in our negotiation. We'll see how it goes tomorrow.
Recognizing the member for Prince George Falmouth.
Thank you very much to my colleague. I know she will have additional questions in her own estimates, but I appreciate the work that we do collaboratively. It's a real pleasure to work on the files together. We're going to have to pick up the pace here, so I'd like to work our way through some very specific questions. Let's start with the UBC ophthalmology program. In January, there was a report that there was a risk of losing accreditation related to the UBC ophthalmology program. Can the minister identify for me whether that issue has been resolved? We know that BC is training only 3 ophthalmologists per year and retiring close to 6. So obviously a great deal of concern about that program. Have those issues been resolved?
Minister.
We were made aware of the issue. We understand UBC's been dealing with it. There were some HR issues related with it, and that they've dealt with it. And they're regular accreditation issues, but they're dealing with those issues.
Member.
Well, I am certainly hopeful that the minister and the health ministry have made it clear that we do not want to be losing our ophthalmology program. We're at risk already of having not enough professionals, so I will look forward to an update on that. I want to move to the issue of ER closures and staffing. Does the minister have data related to emergency health room visits for 2019, 2022, so that I can have an understanding of the total number of unique patient visits to ERs? So is there data that is broken down by health authorities, areas, or facilities? I'm hoping he could provide that data for me. Obviously, we don't have time to read through every line of health authority or facility, but first of all, can the minister confirm there is data, and do we know the total number of unique patient visits from 2019 compared to 2022?
I'm sorry, member.
Maybe while the staff is looking for that information, we'll move on. I have a lot of questions, and we are not going to get to them at this rate.
Minister.
We'll absolutely provide, as requested, to the member in advance of the beginning of estimates tomorrow. That might facilitate it. We do get those numbers also on a daily basis. Interesting, so what it was yesterday, and we've kind of used the baseline, the pre-COVID baseline of about 6,500 visits a year to ERs, and we're typically above that. I think the average is closer to 60 The average during COVID was 6,755. So the pre-COVID 2018-19 was 6,514 a day. 2019-20, 6,600 a day. So we can get the details on that. And that in 21-22 is 6,755 a day. And the post, what we call the current period, which is 22-23, was approximately 7,200 a day. So you can see the increase over time.
Member.
So what I would like to see is data that shows me local health authority areas, and because what I want to do is, so if the minister could share that, I want to be able to look at whether initiatives that are taking place are actually lowering or changing the pattern of appearing at an ER when you have other places that you could actually be going. I want to walk through a series of questions, and again, the minister can either just quickly answer them or provide me with information. Obviously, I've had a lot of people concerned about Elkford. The Elkford ER has been closed for nearly 19 months. Can the minister confirm if the emergency department in Elkford will fully reopen by July?
Minister.
So I can give the member quickly, and there's some information on physician staffing because it's really important for her colleague from Kootenay East as well, who we're in touch with regularly on this issue. So Interior Health has filled all vacant Elkford physician vacancies as of July 2023. That the physician resource plan for Elkford calls for 2 FTE of physicians to support primary care and ED services. And this is a change, and this is a hiring, so it's really exceptional effort, in this case very much personally by Susan Brown, who's our outstanding CEO in Interior Health. Currently, Elkford has 1 part-time physician working 0.5 FTE and 0.4 FTE nurse practitioner. The latter is currently on leave, so that's where we're at now. So the site is supported by locum physicians now, primarily out of Fernie. So there is, as of July 2023, a full complement of physicians is expected to be in place. And that's 2.0 FTE split between 4 physicians. Sparwood, which is a neighboring community, as the member will know, has a full complement of 5 physicians since August of 2022. And there's other information that if the member would like, around other services and lab staffing that I can share with the member and the member for Kootenay East, who I know is interesting. I know she's representing him on this issue.
Member.
Thank you. I remain hopeful that we will resolve that. And I guess my overarching, when I go through and I think about the circumstances we're facing, the minister now has a parliamentary secretary for rural health. And there has never been a time like there is now. Well, actually there was. I remember that, a very large rally in my community and a very large hockey rink. Yes, I do remember that. But these are significant issues in rural communities. And so I am hopeful, perhaps the minister could describe for me the connection and work a plan that the Parliamentary Secretary for Rural Health has. But in the meantime, I would like an update on Merritt. We have people in Merritt that, that ER has been closed 8 times this year, and it's only April. And if anybody has actually driven to Merritt, through Merritt, we have winter weather during the period of time when some of the most challenging conditions, and I can just tell you that lots of people where I live have to travel that way for sports, for families, for all kinds of things. So again, a significant concern about merit. So can the minister outline for us, because I'm sure the protests will continue, what exactly is being done to create some immediate solutions to stop the closures? And perhaps at the same time, maybe the minister could answer about merit while we're looking up Chetwynd, because Chetwynd has had numerous diversions and interruptions. Again, what recruitment strategies and funding are in place to put an end to that? I would also like to know, and we don't have to do it right this minute, but perhaps the minister could provide me with updates. What is the timeline to reopen emergency services fully in Port Hardy and Alert Bay? In February, Eagle Ridge's hospital's emergency department had only half the nurses it should have, and 1/4 of those were provided by for-profit agencies. So could the minister tell me how many vacancies there are at Eagle Ridge Hospital? And so the minister gets the point here. We have people in parts of British Columbia who are unable to access an emergency room. So those are just a few that I chose to highlight, but we know that province-wide there are significant challenges, particularly in rural and northern communities. So could the minister at some point provide me with updates on Merritt, Chetwynd, Port Hardy, Alert Bay, and Port Moody, and perhaps now just speak to the general issue of emergency room closures, and I can wait to hear the details on each of those other ones.
Minister.
Just to go through them, because what we take and what's very important in the case of closures is they have an impact on the public and on public confidence and the sense of support for the healthcare system. So last year, when we were discussing this issue, we were focused on a single community which kind of symbolized at the time, which was Clearwater. There hasn't been a closure there since Labor Day. We worked together with the community on a longer-term solution, and while we still have lots of work to do in Clearwater, a solution was found and put in place. With respect to the North Vancouver Island, the Mount Waddington area, similar actions are taking. I introduced a comprehensive plan working for the member from North Island and the Parliamentary Secretary for Rural Health, and I'm happy to respond to that, but I don't think the minister wants the member wants a long response on the Parliamentary Secretary. I'm happy to talk about her work and the work that she's doing. But in that case, a multi-point plan that addressed emergency health services, adding new services in terms of diagnostic care, which will improve health services in that region. The efforts in terms of nursing recruitment and doctor recruitment in that area are laid out in a specific plan. I'm happy to share that with the member. With respect to merit, it's a high priority for me. I've had a number of conversations with the mayor of Merritt on these questions, who is obviously concerned on behalf of his community, and there's a very significant effort going on both on the recruitment of doctors and nurses. The most recent closure was related not to a doctor shortage, but a nursing shortage in that community, and we have a major effort in place to continue to support that community, indeed to add services to Merritt. We've talked about Elkford, happy to provide more information about Chetwynd as well. I'd say in general, what we're doing is our broader response is the Health Human Resources Plan we've been talking about, with the specific improvements for rural health and rural physicians and rural nursing that's found both in our actions on retention, our actions on recruitment, our actions with respect to internationally educated nurses and doctors and health sciences professionals that you're seeing. So these areas are illustrate when there's less flexibility and there's more broadly increases in absences in the system, because we are trying to go from a system of people staying home when they're to a system where people stay home when they're sick, from a system which often drove presenteeism in the healthcare system in a way that wasn't healthy for healthcare workers. So in each of those cases, they have the highest possible priority. You've seen the work that's been done in Elkford. The work that's been done in Clearwater is similar to the systematic approach we're taking in the north of Vancouver Island, in Merritt, in Elkford, in Chetwynd, and other communities that the member has outlined. And I think it's that work. We need to take urgent action, and that urgent action sometimes requires agency nursing, and we've seen that. But what we're looking for is long-term stable solutions that bring back that sense of confidence. No one wants to see an ER close. Occasionally that happens because we have to maintain certain standards. We don't want to see it, and that's why we're taking actions to address these issues in the long term and in the medium term, and that requires specific recruitment in those communities. So that's what we're trying to do. I think I touched on just about all of them, but I'll review the blues, and if I've missed community, I'll provide the member with a response when we start tomorrow morning.
Member.
Well, thank you. And I know we're into the rapid fire section here of these questions, but what people in these communities want to hear from the minister is a commitment that those ERs will be open, that they will be that we're not going to see diversions and closures, and that there will be timelines. And, you know, when you think about Elkford, for example, I mean, they've been waiting and uncertain for, months and months. Could the minister just specifically speak to Chetwynd for me? I want to be sure that I understand if there are specific recruitment strategies in place and if there is funding in place to put an end to emergency department closures in Chetwynd.
Minister.
Well, Chetwynd is a high priority too, as are other communities that face challenges in the north. I'm thinking of Fort Nelson, I'm thinking of Tumbler Ridge, Chetwynd, Hudson Hope, but also towards the other side, Hazelton and others. So we talked, I think yesterday or the day before, about the travel resource pool. That applies to Chetwynd. The prototype rural retention incentive applies to Chetwynd. The housing pilot applies to Chetwynd. The child care pilot, which we're trying to provide support and trying to extend to communities such as Chetwynd, and all of the retention bonuses and other elements that are part of that, because nursing is critical in Chetwynd. So it is a priority as well. There are, of course, resources there, and Northern Health is working very hard with people and the community in Chetwynd to provide support, as they are in communities such as Mackenzie and Tumbler Ridge in the region.
Member.
Thank you to the minister, and I'll look forward to some additional information on some of those particular sites, but the overarching issue is a challenge in many parts of British Columbia. I want to move on to a topic that I raise again this year, and from my perspective, I fail to understand why the answer to this question is not yes. Not we're looking at it, not we've been looking at it, and that is the issue of physician assistants. I'm sure the minister has seen the map recently, and British Columbia stands in splendid isolation. Most jurisdictions across this country have said yes to physician assistants. Soon we are going to be the only province that is not utilizing physician assistants. So, straight up question to the minister, is he prepared now to look at physician assistants as part of the solution to the myriad of issues and challenges we have been talking about for this is now day 3. We have seen representatives from rural communities, from Fort Nelson, Elkford, New Denver. I'm certain the minister has those proposals. Last year, the minister said that there was a lack of training, and that seemed to be a roadblock. Well, other jurisdictions across this country have somehow managed to figure out that this is a position that would help reduce the stress and the congestion and the workload for physicians. So, to the minister, will he today commit to introducing physician assistants in British Columbia?
Minister.
So, remember, talked about a number of communities. We're talking about an extremely small number of workers. The point I made last year wasn't a training question. We don't train physician assistants in BC. In fact, they're trained in Canada. Talks about multiple provinces, only in Manitoba and Ontario. Those are the two places that they're trained. There's the potential, I think, in BC, potentially, of some 40 to 50 physicians assistants who could be authorized for practice. The College of Physicians and Surgeons is doing work on that area to see what that would be, but it would not be. It would be a limited group of workers, and potentially they have access to work in BC, and the college can, as I know, working on that question to make it happen. But when you look at the Health Human Resources Plan and the integration of a small group of workers is something that is being considered, and that would require the college to set the standard for that, which they're looking at, and that would be a very limited introduction of support. So if people are looking for a big response, that's why we're doing associate physicians and adding nurse practitioners and tripling those numbers and adding nurses and expanding the scope of practice across profession. College of Physicians and Surgeons is looking at whether and how physicians and assistants would be licensed to practice. And I look forward to that. And once they do that and announce that, there may be a possibility for that. In the system, understanding, and I know the member understands this, that there's a very small number that would be eligible to practice in British Columbia. We're not training them, and there wouldn't be a plan there to have training here, to establish a training mechanism here, but simply to the College of Physicians and Surgeons is considering the way in which that number of people would be eligible for practice, and then potentially, if they do that, they would be eligible to practice in British Columbia. So I know there's a lot of talk about the issue, but it's a relatively small group of workers, so it couldn't be integrated across the province or across healthcare systems because there's simply not the numbers of them. And obviously, our focus in terms of education has been in allied health professionals, in healthcare workers, healthcare assistants, ambulance paramedics, nurses, doctors, pharmacists, and others, right? And so that's what we're doing across the system. So the College of Physicians and Surgeons is looking at that. Physician assistants, I suspect, could soon be eligible to practice in BC. But then again, I just say to the member that it's a relatively small number of physicians assistants. It would not be our plan to establish a training system here in British Columbia for that because we're focused in our health human resources plan on other things. But once the college does that and sets the guidelines, physicians assistants might well be eligible to practice in BC, and obviously we'd be making that announcement.
Member.
Okay, thank you to the minister. That was definitely not a clear up yes, that's for sure, and I would have hoped that would have been the answer. Here's the great news. There are physician assistants who want to come to British Columbia to work. And guess where they want to go? They want to go to parts of British Columbia that are in desperate need of additional healthcare professionals. So from my perspective, this is something that we need to get past all of the reasons why it's complicated or we can't do it or we're thinking about it or we're monitoring it. Other jurisdictions in this country, including Alberta, just recently said, yes, come on aboard. And I think it's 40, actually, that they're looking at. And I can assure the minister, whether it's a small number or not, we have physicians that are asking this minister to put, for example, together a physician assistant pilot. And even that would be a start. What it would do, and in fact, I'm sure the minister is aware that the Conference Board of Canada has actually even looked at the effectiveness of and efficiency gains and time savings when there is a physician assistant. So I don't know how many more times I can ask and how many more times we can get the same answer that we're looking at it, we're thinking at it. We have a healthcare crisis. Everywhere we go, we talk about the people we need. Here is another way, and from my perspective, it's all hands on deck. Let's figure out how we make it work. So I'll leave this. I will give the minister one more opportunity here. What concrete steps will he take immediately to ensure that physician assistants who want to work in British Columbia are welcomed here as they are being welcomed all across Canada.
Minister.
In terms of their scope of practice, those are the scope of practice that will be established by the College of Physicians and Surgeons. But I'd say in the last year, I just repeat across Health Human Resources, 2,000 internationally educated nurses in the pipeline, massive changes in every aspect of healthcare to build out Health Human Resources, a Health Human Resources plan that I think is the envy of the country, a collective agreement with doctors or master agreement with doctors and a reform of the system that has been remarkable in success. The increase in nurse practitioners from last in the country to the fastest rate of growth of nurse practitioners, of nurses, of LPNs in the country last year, of health sciences professionals, a 26% increase in health sciences professionals. And in this area, which is an area of interest to the member, there will be put in place, I suspect, from the College of Physicians and Surgeons, a scope of practice for physicians assistants as a category of workers. And when that comes into place, we'll have some announcements to make. But it has been the remarkable buildup of team-based care, unprecedented in the history of the province over the last few years, that's reflected in our Health Human Resources plan. So I've answered the question on physicians assistants. There'll be a scope of practice laid out by the college, and then from there we would take a look. But there isn't a plan, just so everyone understands. Right now it's just Manitoba and Ontario. There's, I think, 3 programs that provide new physicians assistants in Canada. There isn't a plan to add that in our British Columbia mix of this sort of massive response to the Health Human Resources situation. So that's the response. Our priorities have been what we know, and those priorities have been in the last year remarkably successful in BC relative to any other jurisdiction in the country. Number 1 on nurses, that's important. Number 1 on physician recruitment compared to other jurisdictions, and all the success that we're seeing now. And let's acknowledge this, all the massive challenges facing the system that we've been canvassing for days and days and days and days. So on physicians assistants, the college will address the issue of scope of practice, and we'll go from there.
Member.
Can the minister give me the timeline for the college to finish looking at this issue? And I'm simply going to say it again. I certainly am not standing here suggesting that, any addition to healthcare professionals and the number we have and the places that they go to serve isn't important. Of course it is. The whole Health Human Resources strategy talks about if we don't have people, the system is not going to function. Here is a group of people that could help remote communities particularly. They could help physicians, for example. Other jurisdictions have looked at this issue and said, we welcome you. And yet in British Columbia, I can't tell you, this must be the 3rd set of estimates where I have raised this issue, and the answer is virtually the same. We're looking at it. Well, it's long past the time to look at it. It is time to do something about it. So my final question for now, I can only urge the minister to, frankly, get on with this and make sure that we have every single person who can help us, and we have physicians who are willing to look at piloting, to demonstrate the value, despite the fact it's going on across the country. Can the minister tell me what the timeline is for the college to finish looking at this issue?
Minister.
I expect it to be soon, but again, I would say there's 2 provinces, 2 trained physicians assistants in our country, 2. And we estimate, and it's important when you're integrating groups of workers, we're building out a team-based care model that sees people expanding their scope of practice across healthcare professions. It is, I think, a remarkable change to the healthcare system that's taken place over the last number of years to build out team-based care across the system. And so I appreciate that the previous government, for example, with nurse practitioners, Minister Abbott brought nurse practitioners to BC in 2006. 11 years later, we were a miserable last in the country. We've gone from now 300 practicing to 900 practicing, that's an extraordinary success. And we're going to continue to do that and to drive that kind of innovation and reform in the system. And again, and once the scope of practice is established, that will tell us the usefulness to the overall system of extending opportunities to this group of workers. I've met with physicians' assistants, and I hear the public call, but I want to be very clear that the massive investments we're making in health human resources and the results that we've seen as compared to other provinces, understanding the real challenges faced in the system, are remarkable, and I'm very proud of them.
Member.
Well, I can simply say the debate isn't about whether we train them or not. It's whether we recognize them, make sure they're certified, and have them participate in team-based care in British Columbia. It's pretty straightforward from my perspective, and we continue. We were described just this week as isolationists because when you look at the map, we're standing out all on our own. I love to see British Columbia lead, but not in this area. So I'm going to continue to press the minister and the ministry to do the work necessary to make sure that we have all hands on deck. And speaking of all hands on deck, can the minister tell me how many associate physicians are currently employed in BC in acute care and how many are in community primary care?
Minister.
So just to take the member through some of the information around associate physicians, I just say on physician's assistants, this was a proposal that was repeatedly rejected in the years between 01 and 17. I just want to say that it was rejected for I'm sure good reasons, right? So I'm just saying that when I say that we take these issues seriously, we take these issues seriously, and I'm sure that previous health ministers, including the leader of the opposition, had good reason at that time. Circumstances have changed, I think it's fair to say, and the position is different. But I want to say that we take it seriously too, and we're working our way through those issues with people. And had those decisions not been made, of course, the circumstances would be different today. With respect to physicians' assistants, as we see it, there's 461 prospective candidates. There's sometimes talk of thousands of people. We identify 461 prospective candidates. Of these, 204 currently hold Canadian work status, and 257 require immigration support. The total planned programs is 75. And the total planned hires is 255. It's just starting. There's 6 accredited programs of the 75 in place. The accredited programs are currently in specific areas. They're in the Provincial Health Services Authority, so they're pediatrics, neonatal intensive care, pediatric intensive care, surgery, pediatrics, gastroenterology, and in the Providence Healthcare at St. Paul's, inpatient medical and surgical programs. So they all have to be accredited. Those are the 6 that are accredited. There are, as I understand it, 7 hires, 20 postings, 6 accredited programs, 255 planned hires. That's the information I have for the member. So those are the areas that are accredited, those specific areas. So none of those yet are primary care, but it's our expectation. Those accreditations are required by the College of Physicians and Surgeons. It's the primary care accreditations are coming, but those are the areas that have been approved and accredited so far.
Member.
Thank you very much, Madam Chair. I will resist the temptation to respond to the question about physician assistants, and I have looked them straight in the eye and had the discussion about those things. And yes, circumstances have changed. I'd like to move on to specialist access. One of the most difficult conversations I have had in a long time was a conversation with a specialist who described the unbelievable agony on behalf of their patients of what is called wait one. And wait one is the period of time that it takes for your first consultation with an oncologist, for example. And what I was told was absolutely devastating, because once again in that conversation, reflecting the views of a large number of specialists, was the moral distress that those specialists feel when there is a diagnosis and you are waiting for that first consult. So what I would like to know, is wait time data available by health authority and specialist? And will the minister commit to providing that data publicly?
Minister.
Thank you. It's good to see you, Honourable Chair. There is, first of all, just because it's important to make progress on these areas too, there's specific funding for specialists in the new master agreement with physicians over the next 3 years to address fee-for-service specialist disparities in compensation and to assist in recruitment in that process. The Wait One data is something that we've been focused on with the doctors of BC, and it requires us to go for that data as opposed to the general surgical wait time data that we see specialist by specialist, and that work is being done now because it's important that we have that information to focus in on that, and that hasn't typically been held over time. And part of the important work we did in working with the doctors of BC, not just for primary care, which we've discussed, but for specialist care as well, is to focus in on those issues. And those tables are some of the most important work we're doing in that specific area that she identifies of Wait One. Specialist wait times is an area that we are focused in on the data and working sometimes clinic by clinic and specialist by specialist to confirm and then authenticate and confirm the data which is required to be done. So we're doing that work as well. As a member will know, obviously we've done very significant work with surgeons on the surgical side. This work to increase outcomes, and the results are there for all to see under surgical renewal, and the work that's been in diagnostic care to increase that capacity dramatically over time. And so the specific work about around Wait One is a priority for the doctors of BC for specialists, and one we're doing with them right now.
Member.
Thank you, Madam Chair. I don't know if there's ever been a letter like this before, but the minister months ago received a letter that started out apparently with 26 signatories and ended up with 319, I think it was. It was over 300 anyway. And it came from multiple specialties. And when we talk about wait one and we talk about delays and we talk about what are we going to do about that, the list talked about things like a patient with sudden hearing loss who if they had been seen sooner wouldn't have been permanently hearing impaired. 16,000 people waiting for an echocardiogram. Patients on the Lower Mainland with new cancer diagnosis waiting 2 to 3 months for their first visit, wait one, to an oncologist. A lone respirologist in Northern Health, unable to recruit partners who had to close her practice. The list goes on. So I understand that there have been steps taken in the master agreement. I am not confident that that is going to deal with the crisis that we are facing, with 1 million people waiting to see a specialist in this province. So one of the things that I have heard consistently is that specialists want to know that they are valued. And a lot of the hours that they work are not remunerated. And obviously that leads to burnout. So I would like to ask the minister specifically some questions about the physician master agreement. So did the master agreement raise the daily cap on the business cost premium by 12%? And does the minister fully believe that that will fully address specialist costs and the significant overhead costs? Or are there discussions, as minister and the ministry having discussions about that gap?
Minister.
So post the letter the member refers to, we set up a group with specialists to work through some of the very issues they've raised. At this point, in terms of the physician master agreement, yes, there is an increase as described, and we're going to get the exact number. I think the member said 12%, just to make sure I got that number, we have that number right. As noted on specialist physicians, in the physician master agreement, new funding to address fee-for-service specialists disparities. 90% of that disparity funding is intended to address intersectional disparities in compensation, and 10% to address what are called interprovincial disparities in compensation. Remember, we'll know, for example, on oncologists, we made a very significant move recently to address that, and we're now #1 in the country. We were trailing Alberta by some significant number. I think the number was around $60,000. We've addressed that. All the funding will be allocated through a single binding adjudication process based on submissions of the sections, the Doctors of BC and the government. And in making that decision, the adjudicator will consider disparities arising from gender differences. That addressed an issue the member raised earlier. There's also new fee funding for specialist physicians, for the consulting specialists of BC, and that is set based on priorities that they have set themselves. There's also a new annual funding for the Specialist Services Committee for initiatives to support specialist care system, including those raised in the letter. Those are significant moves in the agreements and the other moves we're making to support specialist care in BC.
Member.
Thank you, Madam Chair. Has the minister met directly with specialist physicians?
Minister.
On the committee in question, it's been at the deputy level, and I meet with specialist physicians on a regular basis, but that process, the committee process, has been established, a permanent committee, and that's been through direct meetings between the specialist physicians and the deputy minister.
Member.
Thank you, Madam Chair. The medical on-call availability program is another concern related to the physician master agreement that was raised by consultant specialists. Is there work underway to address the gap that they believe exists there?
Minister.
Yeah, in fact, a 10% increase across the board in MOCAP, which is a significant increase.
Member.
I may be inaccurate. When I was doing this work, but I thought that the recommended increase was at least 30%, and that the eventual outcome was 10%. Is that correct?
Minister.
Well, the newly ratified PMA resulted in a 10% in MOCAP rates for all level 1, 2, and 3 groups effective April 1st, 2022. So we negotiated the agreement, and then it was retroactive to that. And so that was the agreement that was negotiated and obviously approved by both sides in that agreement. The member may be talking about something else, so perhaps we could discuss that after, so that we make sure we get the right answer. But that was the negotiated number, was obviously negotiated in the collective agreement and massively approved by doctors.
Member.
Well, I think the consultant specialists actually asked or at least recommended a 30% increase. So you can imagine that they consider that to be a gap with what was delivered. So I need to move on in terms of some of the other questions, but I just want to reiterate for the minister, and I know he knows it because we've known each other for a long time, but you know. The message that was delivered to me by specialists across this province is that Wait 1 is being extended, and people are literally stuck in Wait 1, and that is causing enormous personal moral distress for people who want to see patients in this province get the best care possible. Those were very difficult conversations, but I listened and committed to raising this issue. When we think, I can't even imagine, I'm sure many of us have walked alongside people who have been waiting to hear from an oncologist, the agony and the difficulty. And it's obviously for patients and families, but it's also for the people who care for them, who feel like they can't do the job that they want to do and are called to do. I want to move on to nursing, to ask some questions about nursing, and I have a number of areas. I want to raise the issue of safety, and we know that occupational health and safety is absolutely essential if we're going to retain nurses in the healthcare sector. Can the minister tell me what percentage of staff are currently Code White trained amongst healthcare professionals in BC hospitals?
Minister.
So what we'll seek to do is, on the specific data the member required, what I'll seek to do is find that data and I'll probably end up sending her a response. They don't have it exactly in the form she's asking for. But just to say, obviously, the creation of the new relational security model, and I gave the member a detailed answer on that earlier in response to another question about where we were in the hiring process. The leads have been hired. The Switch BC, which has been created to address specifically occupational health and safety and funded to do so, and led by healthcare workers, including nurses and healthcare workers and health science professionals and doctors, has been put in place. The hiring process is in place, the curriculum's being developed, and that's really based on the recommendations by healthcare workers to improve safety and security in workplaces. It's a critical part of our health human resources plan, and really it was developed based on the work of healthcare unions, of healthcare workers, of health authorities, and of course now Switch BC, which has just been created. As we say, I won't say this again, the previous occupational health and safety agency that was similar to Switch BC was eliminated by a previous health minister, the current leader of the opposition, and we recreated it because it was necessary in this time. And I think, again, we talked about times changing. Well, this is a time when Switch BC can play a critical role in all of that development, as can the new relational security model. And again, we can go back to Hansard to show specifically who's been hired, where we are in that process, and the training that's been developed to prioritize that in healthcare facilities across the province.
Member.
Thank you, Madam Chair. What are the requirements to document a code white when one is called? And where there are external security providers, which we certainly see in some hospitals, and I'm assuming they track safety and security data, how are those records made available? So what are the requirements to document, and what are the expectations of external security providers?
Minister.
Thank you very much, Honourable Chair. All code whites are documented. They're kept in a record base for that that's held by the Provincial Health Services Authority.
Member.
So external security providers provide that information, and it is captured in that database.
Minister.
It's health authority staff that record it, and so it's not external. The health authority staff, it may be that external staff, we have lots of contracted security in the province, they might respond to those circumstances, but the code white data, that's maintained by health authority staff.
Member.
Thank you to the Minister for that clarification. I'm wondering, when there is an incident of workplace violence, what is the expectation following the completion of an investigation? Are there individual incident reports correlated at a facility or health authority to determine best practices or operational gaps? So, in other words, incident, investigation, what happens afterwards to ensure that there are steps taken to either modify or deal with whatever gaps or issues may have led to that particular incident?
Minister.
Well, so the incident summaries would go to the Occupational Health and Safety Joint Committee in say, a facility, and then if recommendations flow from that, they flow from there. So that's the sort of way in which those reports are structured.
Member.
Thank you, Madam Chair. Can the Minister tell me how many protection service officers and violence prevention leads have been hired to date? have started work, basically, and what hospitals they are located in.
Minister.
I think, and it was in response to a different question, I answered this question earlier, so, but just say that of the 14 leads, 13 have been hired. All the 13 of the 14 leads have been hired, and and all of the 320 relational security officer positions have been posted through the health authorities. And the training program that they would go through once hired has been being developed by Switch BC.
Member.
Well, thank you. Obviously, the announcement was made in October of 2022, and the government announced 320 in-house protection service officers and 14 violence prevention leads. Can the minister tell me what the timeline is to hire all of those protection service officers and violence prevention leads?
Minister.
And this is, as announced, it's on track as announced. What I might do is share the sites. I think the member asked about the sites, but I can just share that information. I don't have to read the 26 sites. The leads have, as I say, been hired, at least 13 and 14, so substantially hired. The training content complete has been completed, or it will be completed by the end of this month, or this week. The hiring will take place May 2023, and full implementation is for September, which is within the time that we presented when we announced the program.
Member.
Thank you, Honourable Chair. Can the minister tell me how the initial 26 sites were selected?
Minister.
So the 26 sites were initially identified by the BCNU and other unions, and then the health authorities added to those sites. And so that's how we got to these 26 sites. And I think they've already been listed out in public, but I can share those sites. But that's how they were developed. They were developed from the workforce representatives, including the BCNU and the HU and others. They identified critical sites, and then the health authorities added some other sites as appropriate. So you see it in different communities. On Vancouver Island, that model is already in place at many sites. So these 26 sites only include a couple of new sites in addition to existing sites on Vancouver Island, but they include 3 sites in Northern Health, 7 sites in Interior Health, 3 sites in Vancouver Coastal Health, 2 sites in Providence Healthcare, and 8 sites in the Fraser Health Authority. So in Northern Health, it's Mills, it's Prince Rupert, it's University Hospital of Northern British Columbia, for example. But I'll provide the member with the full list, which I have here.
Member.
Well, thank you to the minister for that. I mean, obviously, after the announcement, I had a stream of MLAs in my office asking, why not us? Because I'm sure there are concerns in every community. And, I know that I spend a lot of time working on files with my colleagues, particularly from Caribou North, who spends a lot of time dealing with issues supporting nurses. Will the model be extended to other healthcare facilities? And when would the minister anticipate, obviously we don't have workers in place yet in all of those sites. We hope to by the fall. Will the positions be expanded, and how would additional sites be added?
Minister.
Thank you very much. I think it's fair to say, Honorable Chair, 26 sites as you're launching a program is an ambitious program. All 320 positions have been posted. The leads have been hired, essentially, except for one, I suppose. 13 of 14. The plan is in place. These 26 sites were identified with workers as the priority sites. But absolutely, one would see the program expanding, and of course, also work to bring into the health system, as we have done with other workers who are currently contracted out. So all of that work is taking place now and continues to take place, but we're looking to launch fully at the 26 sites, 320 positions as committed to, and that process is on track, on time, and on budget.
Member.
Thank you, Madam Chair. Having a safe workplace is pretty critical, and all of us have heard stories from nurses, horrific ones, actually. So the sooner we get this program up and running and available in more than, for example, a small number of sites in Northern Health that has the geography of, 2/3 of the geographic land base of British Columbia, that really matters. And all of us in this House made a commitment to work on ensuring that nurses felt safe in the jobs that they hold. I want to move a little bit to recruitment and retention of nursing. We've had some discussion about that earlier today related to the Health Human Resources Strategy. It's something I've been very frankly disappointed by, but surprised as well. When a nurse chooses to leave their career, leave nursing, leave the public healthcare system, can the minister tell me if there is an expectation that there are exit interviews completed every time?
Minister.
It wouldn't, of course, just be nurses, but health sciences professionals and healthcare workers and others. So, I mean, I think it's fair to say at some sites, such exit interviews take place, not at all sites. It's not a across-the-board policy, and I'll take that as a suggestion from the honourable member that they look in that direction in terms of retention, but certainly that work is taking place. I would say, as we start the discussion of nursing, that on registered nurses led the country in new registered nurses, and not just in the last 6 years, but in the last year dramatically so. 6.7% increase in BC, a 0.7% decrease in Alberta is an example of that. And I think that reflects the commitment and the work of BC nurses, of the government, but also of the BCNU and at nursing sites, and really the dedication of nurses in BC, the efforts we made during the COVID-19 pandemic to bring nurses back into the system and increase the training of nurses. But it's also fair to say that we started in 2017 a lower base than other jurisdictions. That's true of nurse practitioners. That's true in the last year of licensed practical nurses, where they increased by 8.4% in a year against, in that case, 5% increase in Alberta. So all of that, that's net increase against, so that's not just new nurses, that's net increases. So that addresses retention and training and recruitment of nurses. But we have to do better. and especially on retention. And that's what putting in place, saying we do a relational security model and then putting it in place, working with Switch BC, which the BC Nurses Union and other nurses have direct responsibility for, is important. So those steps on retention, on recruitment, on training, and on making changes to the healthcare system. All of those are part of the Health Human Resources Plan, and nurses are critical to that. There are by far our largest group of healthcare professionals, and obviously all of the changes that are being put in place for recruitment in our recently negotiated collective agreement add to the significant improvements that have been made in the last number of years, but certainly as well in the last year since we last discussed these issues.
Member.
Well, thank you. That was a lot of information that I appreciate, but I'm asking about exit interviews, and I've heard from many nurses that they do not have the opportunity to have an exit interview. And one would assume that if we are trying to retain and also recruit, that one of the things that would show a great deal of respect and value is when a nurse chooses to leave the system, that they actually have the opportunity to talk about why they're leaving. And I think that is a pretty important human resources strategy that would help build value. And I've heard from many nurses who, when I ask that question, actually just shake their heads and say, no. I get everybody's busy, but on the other hand, if we're going to try to create a workplace where people feel valued and want to stay and work, and not only that, we want to attract people, knowing why they're leaving is really important. And being able to close gaps and deal with issues that are identified. And we might also find out that there are certain sites or certain health authorities or certain work environments that are more difficult than others. And we should be working to identify that and fix it. So I would strongly urge the minister to talk to health authorities about the fact that nurses who choose to leave the system for whatever reasons have the opportunity to talk about that. The minister opened the door to a couple of other questions with his comment just moments ago, but I'll ask this question first. So we know that in all of the materials that we see and the comments that are made, there is a recognition that there is stress and burnout in the healthcare system. And we know that healthcare workers are taking, many of them, some of them, we don't know how many, are taking early retirement. And obviously that's a significant concern for us when British Columbians are short of nurses today. So what I'm wondering is, first of all, do we have data about early retirement? Do we have information about who's leaving the system and when? And what I would like, the minister doesn't have to answer with the specifics, he can provide them to me later if we have them. Do we have a way of knowing how many registered nurses, practical nurses, nurse practitioners may have taken early retirement starting in 2019 and moving the way up to 2022? Because we should be looking at whether that number is increasing, what was the causality of those decisions. So I'm wondering, do we collect that data, and do we have the ability to compare 2019, 20, 21, and 22?
Minister.
So first of all, I would say that our legacy human resources systems and information systems in healthcare could provide us with better data. Let's acknowledge that. And that's why we're currently doing an RFP on data on human capital, because that's the priority that the member identifies. Certainly I've identified. I would say that when we say we've increased the number of nurses by between 6 and 7% this year, that's net of early retirement, new hires, and people returning after, in some cases, absences from the system. We saw that, quite a bit of that, assist British Columbia, maybe more than other jurisdictions during COVID, and of course, we're very grateful for that as well. So when we said we led Canada and that we increased between 6 and 7%, and Alberta lost close to 1% net of its registered nurses in the last year, that includes all early retirement and everything else. But the member's right. We need better data on human capital in the system, and that's precisely what we're seeking to get. Finally, and this is critical on early retirement, because this is an issue that was identified in the negotiations with the BCNU and that we're really focused on, and you see that in both the incentives and other things in place for experienced nurses, ensuring that we maintain nurses in the system longer and properly recognize the most experienced nurses and senior nurses in the system. That was a key priority for ourselves and the BCNU and was reflected in those negotiations. So all of those things are in place, I'd say, and but on the data side, we're seeking better health information so that we can identify such issues, not just across the system, but site by site.
Member.
Thank you very much, Madam Chair. I just think that, you know, one of the things that we owe healthcare professionals in British Columbia is a graceful, thoughtful approach to how they choose to leave the profession, whether they're retiring for whatever reasons. The minister doesn't hesitate to remind me about how important the work was that they did, and I agree with that. And I think that our health human resources approach needs to reflect that. That means talking to people when they choose to leave, figuring out what's causing those, in many cases, some of those decisions, and figuring out how that becomes a priority for us to care for the people who care for us. And I think that there are ways that could incrementally improve that. An exit interview, looking at early retirements, why did that happen? And what can we do to bring nurses back into the system? And the minister knows that at some point during this discussion, I am going to ask the question I'm going to ask, and he opened the door for that. British Columbia today, again, stands virtually alone in not allowing unvaccinated healthcare workers to return to their jobs. And the thing that I find difficult to understand about that is other jurisdictions have considered the implications, have considered the place we find ourselves in with regard to the need for healthcare workers, and all of them have decided that it is appropriate to ask healthcare workers to come back to work. And yet in British Columbia, we stand virtually alone in Canada. So I'm going to ask the minister one more time. I know what the answer is going to be, but I feel obligated to answer it, to ask it on behalf of people whose lives were changed. And in British Columbia, they are looking at the rest of our country and saying, what makes us so different? So will the minister reconsider the decision that British Columbia has made to continue the practice of not allowing unvaccinated healthcare workers to return to their jobs?
Minister.
Thank you. First of all, it should be noted that 99% of healthcare workers got vaccinated right across the system. Secondly, I think I'm not correcting the member on the facts, but I'm saying that these are the facts. British Columbia was the only jurisdiction to do that. It's not we're the only one who hasn't returned. We were the only jurisdiction to do that. And at the time we put that in place, the opposition and others did call for us to do that. We were the only ones in Canada to do that. And we did that in order, understanding the vulnerability of the most vulnerable people in society, people living in long-term care and people in acute care, to the COVID-19 pandemic. And because we have that in place, 100% vaccinated across the system in place, it allows us to do other things, including the changes put in place by Dr. Henry a number of weeks ago to reduce some restrictions, particularly in long-term care for visitors in long-term care, and with respect to the use of masks, which in long-term care and acute care. That the issue of proof of vaccine requirement is a provincial health order in BC. It's based on the evidence that's put in place by the provincial health officer and her team. We have consistently in British Columbia supported them. So it's not that I'm saying that's their responsibility and I'm not supportive of that. I have supported them in that up and down the line. Overwhelmingly, healthcare workers got vaccinated, and overwhelmingly they supported that. They support that. It's not just the issue of some; it's the issue of all healthcare workers, and the issues of the 99% who did get vaccinated. I respect everybody. I respect everybody. I understand how difficult those issues were for people, and I respect everybody involved in the healthcare system and everybody in the province. This has been a time of very difficult decisions. And when people make difficult decisions in their own life, I have never, not once, said anything disrespectful of anybody, and the member who has had these discussions with me both publicly and privately understands that. This is a provincial health order. It's one that I support, one that's going to continue to be in place. We were the only jurisdiction in the country to do it because of our fundamental concern with the most vulnerable that defined all elements of our COVID-19 response. Well, a COVID-19 response, and that's why I'm not back and forth or talking about what other people are saying or doing or arguing the disagreement. A COVID-19 response that had remarkable support across the province, and it always focused on the most vulnerable, whether they be temporary farm workers in agriculture, whether they be seniors in long-term care, whether it be people living in acute care, whether they be healthcare workers, that defined our vaccination response and its priorities and continues to define those issues. I think it's important that we continue to provide maximum protection, the people that we can, while balancing that off. And you saw that in the many difficult decisions we made with respect to the opening of schools. Our position in BC was to keep schools open, and we, more so than any other jurisdiction, I think those were the right decisions, but they're often much debated. And I'm proud of our COVID-19 response overall, and I respect the member's position. I want her to understand that. I am not, and I have not, and I will not say anything else but be respectful for people. And just to say this finally, this in our debate, while we disagree on this question, I understand how seriously she takes these issues, how supportive she was personally of our response personally of these issues. So this is an issue that I take very seriously, that we put in place measures in BC, their provincial health orders. They will continue to be in place, and this policy will continue to be in place. We believe it's in the interests of the most vulnerable people in society, and that is our motivation in making this decision. And we believe overwhelmingly healthcare workers support an approach that sees them vaccinated and ensures that in this area of COVID-19, that our healthcare facilities where vulnerable people live and spend time to get well are given the maximum possible protection. So that's the reason for it. And I'm respectful of the question, respectful of the members' desire to raise these issues here.
Member.
Thank you very much, Madam Chair. And, it was June of last year when we called for the return of unvaccinated healthcare workers. And I guess and I'm going to move on, but I want to just, I appreciate the minister's comments about being respectful. I just want him to stop and think for a moment about the statement that talks about British Columbia is doing this in essence, to protect the vulnerable and the rationale that is continually used. And by implication, other jurisdictions across this country have carefully and thoughtfully moved ahead and made the decision to rehire those workers. And I would be stunned if it meant that they didn't care about vulnerable people. So my point is simply this, that other jurisdictions, I can't imagine, went ahead without thoughtfully and carefully considering the impact of that decision. And British Columbia stands alone. And I simply wanted to make sure that our view was on the record and that that call came in June, partly because we looked at what else was happening in the country. We were thoughtful about that recommendation, and we also know we have a healthcare crisis in terms of personnel on our hands. So our position is also based in careful thought, as I'm sure other jurisdictions in this country are as well. I'd like to talk about the internationally educated nurses. I think the minister has covered off the numbers for me in terms of recruitment totals to date. I am hopeful that we will continue to see transparency about with those numbers. Certainly there was a lot of excitement when that announcement was made, and I want to make sure that results are what we focus on, not simply making an announcement that talks about there's thousands of nurses that want to come here. What we need to do is expedite the process so they actually are able to get to work. I'm wondering, I think the minister, but if he could just repeat for me, I think he told me how many bursaries had been announced last year for internationally educated nurses, but could the minister just repeat that for me?
Minister.
Thank you. And just to reply, I don't think we need to go an ongoing debate. I didn't suggest, because the member disagrees, that she didn't care about vulnerable people. I'm very careful not to say that, or that other jurisdictions don't. I'm just saying that this is our position, and we were the only ones to do it through the COVID-19 pandemic. It's not a question of rehiring. The other jurisdictions, Quebec tried and they failed to succeed in putting in place that policy. In number of healthcare facilities in Ontario, of course, it was put in place. They have a slightly different structure to their healthcare, and they put in place some of those facilities. I think still have it in place. So, but I just want to be clear that, and I was very clear when I said it, I think, that that's not what I was suggesting. I was suggesting that is our motivation and the motivation of provincial health for that decision. We were the only ones to do it. And we were the only ones to do a significant number of things in the COVID-19 pandemic, and I think it's one of the reasons why, and our support and respect for public health, that we had such a good response in BC relative to other jurisdictions to the COVID-19 pandemic. With respect to the Action 36, which is the actions around internationally educated nurses, I think I provided before, but I'll go through some of the numbers again if that's okay, because the member was asking about that. It's 2,635. It's updated from when I actually responded to the question before. Have signed return of service agreements. We have 2,997 applicants. 100 of those applicants have completed competency agreements. The college has received about 2,000 applicants. That's up from 641 in 2022. It shows the impact of this. The college has directed 88 IENs to complete remedial education. They're eligible for a bursary to do that, and approved 80 of them for registrations. As of April 20th, 160 IENs and 64 internationally educated healthcare assistants have been hired by health authorities. There have been over 15,000 expressions of interest, and 356 bursaries have been distributed to eligible applicants. So those are the basic information. And if the member needs more, she can either indicate that to me or in the coming days.
Member.
Sure. Obviously, I find myself in an awkward spot here when it comes to discussing some of the issues related to nursing when we're in the middle of voting on a collective agreement. But I'm going to ask these questions, and perhaps the minister would, I don't know, prefer to wait until, I'm not sure what he's able to say either, so I don't want to, but they're important questions from my perspective. So under the tentative collective bargain agreement, there was $108.6 million specifically announced for career development. I'm assuming, and perhaps this needs to be a follow-up response from the ministry, that there will be timelines for each of the initiatives and specific breakdown of what dollars have been put into mentorship support for nurses, clinical mentorship positions, how many will be in each health authority. Those things are important information from my perspective. Also, the $100 million in one-time funding to support nurses in day-to-day operations. I'm interested in knowing what the breakdown of those numbers, what that $100 million is. So I don't know whether that's something that the minister can speak to, whether he'd prefer to document it and send it to me. That's also fine. And I'm wondering specific things, for example, related to the working short premium and whether that's in or out of the agreement. Are those questions that the minister can answer today?
Minister.
So what I'll endeavor to do, because we'll be, the voting on the collective agreement ends at noon tomorrow. So I do have detailed information. I could give an answer without some of the details because we want to go through that process in fairness to the BCNU. But I'll endeavor at the beginning of our 1 o'clock session tomorrow to provide a detailed answer to that question, if that's okay with the honourable member. And then, I mean, I could answer it now without some of those details. So that would mean 2 answers. So why don't I do that in full? If that works for the member, I would appreciate that.
Member.
I've got paper confusion here. All right, we'll skip on past some of those. And I know that my time will be limited tomorrow afternoon, so I'm hopeful that, and I will have a number of other questions. Yes, and if it could be fairly brief, I have a couple of major topics that I want to try to cover off tomorrow, and I know we won't have the whole afternoon tomorrow, so, and I will speak to the minister about that timing. One of the things I want to make sure that I'm on the record about is the issue of nurse-to-patient ratios, and I felt cautiously optimistic when I heard that part of the announcement. I know that I am positive. There must be contract language around that. The minister may prefer, again, for me to get this information later. What I am concerned about is, obviously, it's great to have a ratio. We need people to actually make that work. And so I'm assuming there's some sort of transition to where there is an expectation that those ratios are in place. I am concerned about things like grievances. Is the ratio grievable? Things like that. Is there language that would allow grievances if ratios are not met? There's a number of specific questions I have about the timeline for implementation, and we know that we have 7,000 nursing vacancies at the moment in the province. So I guess I want to be hopeful about nurse-to-patient ratios. I think it has worked in some other jurisdictions. My significant concern is, where are we going to get the people? I think that the conversation when I listened to the announcement, certainly conversations that I've had with nurses, the ratios that were mentioned, they're often, at least according to conversations directly with nurses, they can be much higher than were noted. So the ratios are very aspirational, and, you know, we hear circumstances of very significant nurse-to-patient ratios in some hospitals and in some circumstances. So I guess my question is, we know, for example, that Australia brought forward legislation and a number of things. So what I want to know is, how do we ensure this works? What are the steps? How do we transition? Is it grievable? What is the language? So, you know, again, I'm in an awkward spot because of the timing.
Minister.
Thank you, Honourable Chair. Let me talk generally about it, and then if we want to go into it in more detail, perhaps we could do that. And I'll be brief. I'll just do a brief report off the top. If the member has any questions, and I also commit to our Deputy Minister probably leading a briefing for the member, because I think it's important that we understand this is an important public policy question. It's going to be with us for I think years to come, and I think it's an important innovation. Just on the money, these issues there were essentially two tables. There was the agreement on the table with the NBA, which is the Nurses Bargaining Association, which is primarily BCNU, but includes HSA members and others, as we know. And there was a second table with the Ministry of Health on policy questions, including this one. We are committed to, over the next 3 years, on that question, spending $200, then $250, then $300 million. And that means hiring people, basically. And if we don't spend the full 200, any amount, say we spent 199, and there was $1 million more, that would be spent on initiatives to support nursing. Right? So it's, in terms of achieving this goal over those years, this is a substantial investment in nursing that they're putting forward and putting in place together to improve the situation and to implement that ratio system. So $750 million over 3 years, in addition to all of the recruitment initiatives that are in place in our multiple agreements here on between the Ministry of Health on that table and the collective agreement table are significant. But so that money will be spent on nursing and to address the issue of ratios. And if, for example, we were not able to spend all the money in 1 year, that means that all of the remaining money would be spent on nursing, and that's part of our agreement, and I'd be happy to go into it in greater detail, I think in summary form tomorrow, but perhaps more useful to the member would be a detailed briefing with ministry staff as we develop, because this is going to be an important issue for the healthcare system for years to come. I think it's a great innovation. I'm very proud of our team. I'm very proud of the BC Nurses Union, the Health Sciences Association, and others that were involved in developing it. I'm very proud of that work. It has, I think, proven its worth in Australia and in part in California. And I believe that BC is going to lead in this area and that other jurisdictions are going to follow.
Member.
Thank you to the Minister, and I certainly would appreciate where we get to the place where we can have a fulsome briefing on the contract more broadly. I think that would be helpful. And as I said to the Minister, I mean, I try to be thoughtful about, what will work. And I think sometimes, that isn't partisan. That is, how do we make this work? And what I want to be aware of is, what are the metrics? What are the measurements? How do we press for results? On paper, it sounds like a great idea. The question is, does it work on the ground? And in the context of a situation where we have significant nursing vacancies, it's hard to imagine how we get to the ratios that have been agreed to, hopefully, and we'll see what happens tomorrow. I'm certain that will likely be the case. But I want to go back to the issue that my colleague raised around agency nurses, because it is really causing concern. And the stories that I heard and shared with me and actually talked to people, we want local nurses to be able to work in their communities. The Minister and I talked about this in the context of community health centres and other parts of the healthcare system. But nurses are choosing, some of them, just not to work because they are not given first priority. and when it comes to, at times, agency nurses. So there is growing concern about the number of agency nurses that are being used. So I don't know. I'll ask the questions. The minister can provide them to me, the information to me later, if it's easier. And you may not have the minister may not have it here. How many nurse agency companies are currently operating in BC? How many of them are there? How many are new in the past 3 years? I'd like to take a look at what's happened. And I want to know what the total cost for agency and travel nurses in BC has been over the last number of years, so that we can see. I mean, obviously it has escalated, the cost, and that is a significant challenge. And is it possible for the minister to provide those numbers broken down by health authority?
Minister.
Thank you. And we spoke of this earlier. So over the whole province in the last fiscal year, it was 1.4% of nursing hours. We talked about that. We talked about it being higher in Northern Health. And what I'll do is I'll provide those breakdowns by health authorities, including any information with respect to nursing agencies and other information we have. So perhaps I can do that, because I know the member has a few more questions, and I don't want to occupy all our time waiting for the next answer. But in a general sense, I would say that we use more agency nurses, particularly during COVID, for obvious reasons. We want to maintain the system. We had to bring more people in. And when it comes to providing care for people, I think the member knows that we are prepared to take extraordinary action. But it's not our desire to have more agency nursing. But it is our desire when people are sick in hospital to get staff there. And if staff is available and we need them to fill in, we are going to go do that, regardless of even if the costs are high, because we believe that that's the right thing to do. And I don't think the member is disagreeing with that. It was a fundamental question for us in discussing this with the BCNU and for them to focus on our permanent staff. Even more so, and there was some criticism, the member would have seen this online from casual staff and others, to have an agreement that reflected our commitment to our permanent staff and our recruitment of that staff, which provides stability to communities. I talked about that with the member for Calgary North earlier. So what the member sees is correct. It is more of an issue in the Northern Health Authority than it is in other health authorities, although it is an issue generally in the system. There's more now than there was. And we have to take, and I think the action that we're taking, which is to make this the best place to be an employed nurse in the world, which is the purpose of our actions here, and the purpose of our collective agreement here, and the purpose of our discussions with the BCNU. And the final thing I'd say is this, that we did a lot of work with doctors around their issues in the past year. And that has, I think, shown itself to be successful, but it's successful partly because it renewed our partnership. And I believe that's the work we've also done with nurses and the HEU and the HSA. A partnership together with nurses, a partnership for recruitment, a partnership for retention. Of course there are union management issues, but this is an unprecedented policy work that we've done together to address some of these very issues.
Member.
Thank you, Madam Chair. And I appreciate the minister's response and his willingness to provide some of the data that I think will literally confirm the very things that both he and I are apparently concerned about. The thing that I found most, I think, frustrating was that nurses perceive that, and it's true, agency nurses have a better work-life balance. And one of the significant concerns was that we are hearing that nurses are leaving the public health, our public system, and becoming agency nurses. Why? Because in many cases they get to choose the shifts that they work. There are premiums when it comes to what they are paid, and they end up, in some cases, working right alongside a nurse that they have worked with previously, and now they are an agency nurse. And so there's pay differentials, there are other things that are creating a very uneven playing field. So I want to just be sure that we understand that there is a great deal of concern about making sure that if you live in a community, you get to work in a hospital. And why on earth wouldn't it be that the people who live there and are committed to that community and to those patients get to choose, build the flexibility into the system instead of bringing someone from outside and saying, here, you get your choice of shifts. And by the way, they're the ones that the other nurse needs to be able to care for her kids or whatever it is. We need a system that responds far more flexibly and with an innovative approach. So I'll leave it at that, but I would very much appreciate details and data around wage differentials, the kinds of things. I mean, we've heard stories of, agency nurses taking taxis from Prince George to Quesnel, for example. I would tell you that that is not a cost-effective way to be transporting anyone. I can't even imagine what that would look like. So, I want us to honor the concerns that we're hearing from those nurses who want to do their jobs in their communities. So, if the minister could agree to provide us with that information, and I look forward to seeing how we might be dealing with agency nurses moving into the future. Do I have time for one more question, Madam Chair? Yes?
Yeah.
All right, that'll depend on the minister's answer, I'm assuming. So I don't want to start a major topic, so I'm actually just going to ask a question about something I know the minister and I both care about, that is ALS. We know that, we need to continue to move toward clinical trials in British Columbia. That really matters. We also know that there are very few treatment options available. I wrote to the minister expressing concerns about Albrioza and looking at Health Canada approved that particular drug in June of last year. Health Canada approved it. However, there have been conditions on the recommendation that it be reimbursed on drug plans, specifically that it only be covered to treat those who had symptoms for 18 months or less. And the minister knows this would eliminate many ALS patients. And so I really want to urge the minister to think very carefully about the impact. I know that negotiations are currently underway, but I absolutely believe that we need to think about all of the patients who are impacted by ALS and the fact that a decision to make that kind of restriction or have that kind of restriction would eliminate a lot of ALS patients from potentially a drug that would improve dramatically their quality of life.
Minister.
So thank you. First of all, it is an issue of shared concern. Recently, I met with a young man on this very question in my constituency office, and I'll be meeting with the society very soon on a number of issues, including our work together. And I think we've provided some unprecedented support, and partly I acknowledge it's our joint discussions with the member and her advocacy for patients with ALS and my own that led to that. And I think we have a very strong and good relationship with the society and the effort to support them as they build towards the clinical chair and clinical trials in BC, which is so important to those overall efforts. As the member suggests, we have, of course, advanced in recent times the coverage for Radicava, and that that Radicava, which is Indaravone, which is oral liquid, and Albrioza are currently being negotiated, and those are issues that I have, we personally engaged with the community involved with ALS. So those are issues that are before us. The will know that the drug approval process and the negotiation process is really important to give maximum access to prescription drugs. We've got a very committed pharmacare team here in BC that advocates and is regularly engaged with patients as well. So those are issues that are before it, but I take the members' representation on that issue because it's an important issue, and she'll know that I'll be very much engaged in working with the society and with her, and I will be keeping her informed of progress we make on that file. And with that, Honourable Chair, I move that the House rise, report progress, and ask leave to sit again.
The question is that the committee rise, report progress, and seek leave to sit again. All those in favor? Aye. Any opposed? Motion's carried. Thank you, members. This committee stands adjourned.